Welcome everybody to the Royal Society of Medicine. My name's Professor Julia Manning and I'm the Dean of Education here at the RSM. And it's a pleasure to have you all with us today. We are a leading provider of healthcare education. We've been doing so for about 220 years, although not always online. So you can imagine that's a more recent accomplishment. But we have been a leading provider of continuing learning for not just healthcare professionals, but also for the public. And this is part of our vision for better healthcare, for better lives, and sharing learning and supporting innovation and understanding the latest and the best in healthcare practice is what we're all about. We're independent and apolitical, so we don't take policy or positions on topics, but we are absolutely committed to being a trusted voice in healthcare education and doing what we can to spread learning and understanding. So we are really delighted today to be partnering with Endometriosis UK. And we're hugely grateful to all the speakers who will be covering the diagnosis, treatment, management, pain relief of endometriosis this afternoon. So without further ado, I'm going to hand over to Emma Cox, and we are really excited about having you all with us, both participants and speakers, and we hope you really make the most of this afternoon's amazing lineup. Thank you so much. Emma, over to you.
Thank you, Julia, and a big thank you to the RSM and also to Lorna Hummel-Shoy from endometriosis.org, who has been helping with developing the programme, finding the speakers. And a really big thank you to echo Julia, to all the speakers. We really appreciate you giving up your time. Now, I'm sure a lot of us on the call are interested in endometriosis, but I just want to remind ourselves why we're here. We know that, unfortunately, in the UK, there's a significant average length of diagnosis. The average length to get a diagnosis from seeking help is almost 9 years. And so we're keen to raise awareness in order that people firstly seek help, but also when they seek help, they then get the support they need. And one of the things I just wanted to highlight as we're speaking to an audience that includes medics is that I do think some of the terminology we use historically has not helped endometriosis. So, for example, the definition of endometriosis is where cells similar to those lining the womb grow out elsewhere in the body outside the womb. And we say it's usually of women, and those assigned female at birth, of reproductive age. Now, to medics, that means puberty to menopause. But if you say of reproductive age to anyone else in the public, they think maybe 18 to 43 or something like that. And I think that that's one of the myths that has arisen, that young people can't get endometriosis, but we do know it impacts from puberty. And so I think what's really exciting about collaborating with the RSM and endometriosis.org, as well as Endometriosis UK, is trying to make sure that together we're supporting everybody to raise awareness and to also understand endometriosis too. Now, you don't need to hear me much. We've got a really great lineup of speakers. And one thing I'm keen to do is to make sure we start on time. So I am going to hand over to Catherine Nestor. And Catherine, who's a trustee at Endometriosis UK, is going to be chairing the first session. Catherine, over to you.
Thank you, Emma, and hello to everyone. So I think, yes, so that we keep on time, let's kick off straight away. And really glad that we are starting off to hearing from someone living with endometriosis. And so let me immediately hand over to Jenny Johnson, who is actually a volunteer with Endometriosis UK, but has a long history of living with the disease and has studied the disease also, which led her into volunteering with the charity. So let me hand over to you, Jenny. Thank you.
Thank you, Catherine. So basically with my diagnosis, it started obviously from day dot. I started my periods. So for the first 10 years, I was on and off going to the doctors, and I could be stuck in the bathroom for at least 72 hours when it first came on. So I missed school, I missed college, I missed days off work as well, because obviously with the symptoms, I had numerous symptoms, and obviously I would have the heavy bleeding, a lot of pain. I'd be vomiting as well, and I used to lose the use of my right leg as well. No matter how many times I went to the GP, it was just literally, take some pain relief, you'll be fine. It'll pass, or you'll be done in a couple of days. And even when I was starting to get a little bit older, I was going on birth control. They stopped working after the most, it was 3 months. And then obviously the pain would be back again, the bleeding would be back again. And so it wasn't until that, when I was trying to conceive, that I finally got told that I had endometriosis, and this was by a scan. But nothing was done about that at all for another 10 years until I actually had my first operation. So if I didn't go down that pathway of seeing why, why I couldn't conceive, and didn't go to an NHS fertility clinic, I probably still wouldn't have got a diagnosis for them, obviously, them 20 years. So I got lucky in a sense that they diagnosed me after 10 years, but I still didn't know anything about it. I was just told by the fertility clinic and specialist just to take pain relief. Still, again, it's nothing that needs to be done. You'll be absolutely fine, but we're going to refuse IVF on you because we found endometriosis. So therefore, it can go to someone better who could conceive using IVF. So I was still lost then, and I was still basically made to feel that the diagnosis was basically in my head, even with the symptoms I was still having for obviously the other 10 years, because I wasn't operated on. I tried looking up endometriosis online. I obviously read all the horror stories, even the GPs and the specialists, gynecologists, they couldn't even tell me what it was. So I was forever just in my head about it. And then obviously the GP could be telling me that it was in my head as well, that the pain's not as bad as what it seems. So having to go through all that, it's affected me mentally as well as physically as well. And then finally having that operation gave me clarification that I had endometriosis. But like I say, if I wasn't diagnosed by a scan 10 years after I had my symptoms, then it would have probably been 20 years after I started my symptoms if it wasn't found by a scan, because that was the first time I had my operation, which was in 2020.
Thank you, Jenny. And it's always distressing to hear stories. So, since situation I've kind of been through stuff myself, and so I understand where, definitely where you're coming from, and all the issues around not being listened to, all of the symptoms that you talk about not being taken up. And I always say I'm sorry that you also had to go through all of that. I think it's important that we actually hear what's happening in the clinical professions about this, and how it's being tackled, and how things are improving since your experience and mine. So I think let's hand over to Professor Stacey Nisma, who's going to talk really around the research challenges about getting to a point of being able to diagnose much earlier, which we know is such a huge issue, is the waiting time for diagnosis. If I could hand over to you, Stacey, that would be great. Thank you.
Thank you so much. Jenny's experiences are all too common. And so it's extremely important that from both the clinical world, the research world, the patient advocate world, we recognize that those experiences are not only common, but also that such advancement and opportunity has arisen because patients like Jenny are willing to share those experiences and make sure that we are paying attention to what the barriers are that she and so many others have experienced and how we can intervene. And so I'm going to talk a bit about focusing on diagnosis, but also focusing in more generalities of what has remained difficult in finding new diagnoses and getting people to more rapid care and treatment and support. But genuinely, these difficulties are opportunities. And I don't mean that in a treacly way. I hope that through our conversations over this time we have together, we'll talk about all of those different ways that we're now learning that we can take advantage of to better find diagnoses and individualized treatments. I don't have any interest to disclose. I'm posting here my appointments and affiliations and some of the work I do just for the record and for interest. So what we really want to do is get from a one-size-fits-all to get to treatments that are defined by and personalized by the experiences of, the needs, the preferences, and real evidence of what works best for which people presenting with endometriosis. And one of the key things that has emerged is that we know that endometriosis has many different ways of impacting people with endometriosis, of changing over time. And we've not done a good job yet. And we're now starting to embrace what that means for developing personalized treatments, but also for maximizing the success of diagnostics. And so we know that the disease itself presents very differently. And so I'm not going to show any videos here, but we know that those endometrium-like tissue can present in several different ways. It can be what's referred to as superficial on the surface of the peritoneum. Superficial is not meant to be dismissive or a not important term, but it is literally in the anatomy where the tissue sits. Also, there are deep lesions, and of course, there are endometrioma cysts. Now, we don't yet understand fully what the differences are in terms of how these are affecting not only the appropriate treatment selection, but also how they might affect what we're trying to perturb for diagnoses. And so, of course, we know that whether you're looking at ASRM stage or NZN stage or some of the other staging systems, that actually these different stages don't correlate with the things that really matter to treatments and the clinical care that patients need to receive. They don't associate with symptoms. They don't predict treatment response. And so when we're thinking about those symptoms, another thing that we really have to think across the diagnostics is how they are diverse across patients. Types of pain, fatigue, infertility, other endometriosis associated characteristics. And so one of the things that we and others are trying to perturb, Amy Shafrir and Naoko Sakamoto led this work, is looking at how different patients have different experiences and how that's affecting how they're being diagnosed and how the clinicians are thinking about their endometriosis. And so this is a diagram that shows across about 500 young adults, the average age here was 20, that they presented with severe pain, that's in pink when they first saw clinicians, moderate pain is in yellow, and blue and mild pain, which is in blue. And what this diagram shows is, as we followed these 500-ish patients over 2 years, that they had very different experiences. You can see at year 1, now the proportion who still had severe pain versus moderate versus mild has changed, and then looking at year 2. And so I want to draw your attention to a few patterns. These are the patients who, across these 2 years, remained at that severe pain level despite engaging with treatments. And then receiving very similar, often identical treatments. We have this group of patients who started out experiencing severe pain and actually had it reduced to none or mild pain by year 1. And as you can see, the patients become more and more different and diverse as we move across time, and better understanding what that means and how diagnosis might differ depending on what point in their journey you capture the patient is really important. We also, as we're looking for non-invasive markers for endometriosis, there's microRNAs, there's proteomics, which looks at the different proteins, either in the blood or different media for discovery. And what I want to draw your attention to is not the biologic details behind this, but also highlighting patient diversity and why finding a diagnostic based on these profiles really is challenging, but also a great opportunity if we see patients for their diversity rather than ignoring it. So this is a bit of a complicated figure, but what I want to highlight for you is each of these rows talks about cell types. So inflammation cells and growth cells and highlights pathways of blood vessel development for the tissues. But what's important is these columns are grouping patients by their symptoms. So the first column, for example, is patients who have pain with their periods. The second column is patients who have pain throughout their menstrual cycle at non-predictable time. All the way over on the right, that column is patients with bowel pain. And so what we see here in the blue and the red dots is that for the proteins we find these patients, they are different. And so if we're trying to develop a diagnostic based on these proteins, what we have to embrace is that patients do differ from each other. This also is true for genetics. So one of the things that for more than 20 years has been of interest is finding a genetic diagnostic. And we know now that it is very unlikely that we are going to find a genetic panel, a panel of genes that predict if someone is going to have endometriosis. We now, through leadership from Nilüfer Ramioglu, have found that there are about 118 loci that are associated with endometriosis. But again, reinforcing this heterogeneity, what I want the take-home message to be for all of us together today is that while we are now discovering more and more genes, this now is the plot. So the genes that are associated are above the red line, and the top left is patients who have endometrioma, that ovarian cyst endometriosis. The bottom left are patients with deep endometriosis lesions, and on the right is patients with only those superficial peritoneal lesions. And you'll see that the take-home message here is simply that the grafts are very different. And so that means that there are different genes associated with different types of endometriosis. And so if we're looking for a diagnostic, or if we're looking for the informative biology that underlines these different types, we're starting to see an emergence of differences that we can't ignore. In addition to these symptom and surgically visualized, imaging visualized differences among patients with endometriosis, we also know that the other symptoms and conditions that they experience vary by patients, whether they also have adenomyosis, whether they experience infertility, whether they experience uterine fibroids. But now in the last 10 years or so, we've also learned that patients differ in whether they have health issues, not specifically in gynecology or related to reproduction, but across all health systems. And so we now know that actually those with endometriosis have many other conditions that for which they are at higher risk of. And this also influences what kinds of clinicians they're seeing first on that diagnostic pathway for endometriosis, what conversation there has to be between different care types and specialties. But I also want to really reinforce that these conditions also are not inevitable in patients with endometriosis, and many of them remain quite rare, even in those with endometriosis. So our job next for patients in thinking again as diagnoses and getting to adequate care is who with endometriosis is at risk of developing these other conditions. How is it influencing their path to diagnosis? How does it influence what treatment we need to select? Can we predict who is at risk for some of these other conditions? And therefore, can we proactively, intentionally prevent some of these other symptoms and conditions and health impacts? And then this also very, very firmly reinforces that endometriosis is not simply a gynecologic disease of interest to reproductive health and reproductive medicine, but really needs an awareness at the GP level and across multiple specialties of care. I really want to reinforce that most of the information we have about endometriosis has focused on patients in adulthood. That's because, exactly as Jenny described, and is a very, very common experience, the age at which people get their diagnosis and start that clinical journey is almost always, most often in adulthood. But of course, as Emma and Jenny both described, we know that endometriosis is present and affects well before that. And so we have to start incorporating those earlier life experiences and also those earlier life profiles that may be influencing diagnostics into our consideration. I also want to highlight that everything we know about endometriosis and everything I've described, the entire, all of our discussions today really focus on the people who have successfully been diagnosed and are, for a lack of a better term, are counted in our clinical information, in our clinical clinician providers experience, in our advocacy groups among the patients themselves. But we know that we really don't know what the prevalence of endometriosis is in the broader population. But we know that there are a lot of points at which people can not be diagnosed with endometriosis, that they are missed, that they are underserved, underrepresented. And so across those pathways, what we don't know yet is if they also have unique characteristics, unique experiences, unique biology that would help to better inform our diagnostics and our treatment selection. I want to reinforce that as we're thinking of awareness, advocacy, inclusion, diversity, meaningful differences, and getting to meaningful clinical translations and treatment and diagnostic selections, this takes large collaborative research that includes many different groups, which is also a huge opportunity, but it can be quite difficult. And so one of the things that we're now 13 years ago, we started working on, published 10 years ago, is Worth Effects, the Endometriosis Genome and Biobanking Harmonization Project. This was designed specifically to facilitate these large-scale collaborative studies where we do start to define these unique groups of patients and their needs and their biology that's informative. So we want to improve disease understanding. We need to keep working toward identifying these subgroups to better serve patients and get to personalized diagnoses and care. And really, ultimately, the goal, coming from a public health background, the goal of prevention is not unrealistic. And so again, repeating that these are tools to foster collaboration to get to our goals. And the wonderful thing through leadership of Lona Hommelsoy, endometriosis.org, collaborations with Endometriosis UK, of course, with the World Endometriosis Research Foundation, we now have more than 60 centers across the globe, and we are fostering collaborations across all of these groups. And then the last thing that I really want to say and reinforce is that this type of work also requires collaboration across many different disciplines. And sometimes that means different types of scientists. Sometimes that means different types of clinicians. Sometimes that means different types of advocacy and patient support. Certainly means different lived experiences of patients. And so the difficulty can be encouraging and bringing together these different types of expertise, but also the different languages of among us. And I don't mean necessarily, although that can be true, the way we think of language of, you know, English versus French versus Arabic. What I mean here is that we approach things differently, we prioritize differently, sometimes we literally use different terms. And so embracing and bringing together different expertise, but also recognizing that we need those experts to bring their best selves in their footprint, and that within a collective group, there are some who will be experts on some things, and those same people won't be experts on other things. And so really this work takes the collective. And so again, reinforcing that I view all of this as huge opportunities. And I think I know there's a lot of evidence that we have made advances, particularly in the last several years, because of bringing these diverse people together. It also is a challenge for moving things forward. And so just to leave you on the last comment, as we continue our discussion today with this great Medicine and Me session, is that endometriosis isn't one point in time. It is a journey of both lived experience, but also there may be differences across where a patient is in that journey that's influencing diagnosis in terms of what types of clinicians they're engaging with, what types of symptoms are being recognized, and also the underlying biology that is influencing what those diagnostic tests may be. And so really embracing what we refer to as a life course approach to endometriosis will continue to advance improvements in diagnosis and get us to that personalized, better personalized medicine stage. And so I thank you all. It's a pleasure to be here. And I will stop sharing.
Thank you very much, Stacey. I think what that shows us is that endometriosis continues to be very complex. Obviously, lots of research is going on, and there have been some advances made in understanding it, but it still feels like that there is a way to go for a true understanding of all the entails. But we can get into that a little more in our panel session. So let's move on now to thinking about management, diagnosis, and so on a more practical level. And obviously that normally starts off in primary care. So I'm really pleased that we have Dr. Uma Marti with us to talk about the sort of the considerations about endometriosis in the GP practice. Thank you.
Thank you very much. I'll just share my screen. Okay. I hope start from the thing. Yeah. Can you see my screen? Yep. Yeah. Thank you very much. I want to thank the society for giving me the opportunity, because endometriosis is so close to my heart, and I'm one of the members on the medical panel in UK, Endometriosis UK. Basically, my background was a gynecology, and then about 16 years I was a gynecologist, and 22 years I'm a GP. I'm still a GP as well. So I can actually share my things. I really appreciate Jenny for being very bold and telling her symptoms. It's very, very, what Jenny has said, it's so common we see in general practice. And because I'm a GP with special interest, so I run community gynae clinic. So when they come to me, and I hear this all the time. And I'm really impressed with the research work going on, which Stacey shared. So hopefully I can skip some of the slides because I have too many slides, but I'll come to them. no declaration. I think it's because I'm just a member of this. Let me explain to you. I was a medical student in 1983. First time I entered a labor ward, and I could hear the crying of the women. And I was very young. I was only 19 years old that time, and I could not see the women in pain those days. And then, all the things happened. And after so many years, epidural came. And I was invited as a guest speaker to my same hospital recently, 2 years ago. I wanted to go to the labor ward. I went to labor ward. I was so happy to see women very comfortable with epidural and, playing on their mobile phones, most of them, except the patients who are in active labor. That is one thing, that shows that women they were in pain in labor, and that has been addressed. But one thing is really troubling. Still, pain is there. So it troubles women right from menarche to menopause, interferes with everyday life, cyclical. It could be every month or anything, and it spoils relationships. And I have seen many women, it's like a stigma back home in India. Once a girl gets married, if she has a pain with intercourse, the girl was sent home. This is the sad part of it, that she's not fit to have a normal life. And so is not normal life even to have a child. It's a taboo there. Things are changing, and it's a misery. So what is causing all the problems? The endometriosis, which is also caused as a missed disease. I'm a GP. I work in the primary care. And most of the time I see the letters from the A&E. The woman goes to A&E with pelvic pain. She'll be sent home with an antibiotic for suspected UTI. This is what I used to think. I usually chase that doctor and ask them, have you ever asked about it? So I'm actually trying to do most of these educational sessions to all the specialties, because once they're on A&E, they are the frequent attenders. And we all know that it affects physical, mental, and social well-being. These are some of my examples. You all know a 17-year-old girl wants to become a medical student, wants to go into medicine. She could not because of the pain. And a 35-year-old teacher, chronic pain, she had to give up her, trying to conceive. She could not, and unfortunately ended up in a divorce. And a 42-year-old hairdresser, which is losing her job. She's self-employed. She could not do the job with this. So these are the everyday examples, because I see more and more people. And if you see the epidemiology and all that, it affects any social background, and it's very prevalent, 5 to 10%, and can start as soon as they start periods, which is very, very common. That is one thing which, people should remember, especially the medical team should know about that, So as a GP, I know like asthma is endometriosis, same incidence as asthma. It is like, but asthma has asthma clinics and inhalers. They have special training. And back pain has special clinics, but unfortunately, not much for endometriosis. And we all know that 1.5 million, more than 1.5 million women suffer with this. And it is affected same as diabetes. And diabetes clinics, they run almost chronic illness clinics run. I'm just waiting for a day when a chronic illness clinic includes endometriosis in primary care. These are facts. I'm not going much about it because you all know about most of the facts. And it's a very common condition. But one thing I want to say is the cause of endometriosis is unknown, and there's no definite cure. And I'm very, very impressed with the presentation of Stacey's presentation, that there's so much work is being done about all these on the genetics, on the immunological aspects of endometriosis. Hopefully we find an answer some point soon. And the recurrence rate is also very high. That's about the endometriosis. So because as a member of the Endometriosis Society, I was involved in the various studies. One is the study which is called James Lind Alliance Priority Group. They did a survey, and I was also a participant of that, to analyze the data. They looked at the 10 top questions from the patients. Out of the 10 the top 3 questions I'm just showing you. One is, most of the women, they all wanted, they wanted to know the cure, and they want to know the cause, and most of them, they have put what is the most effective way of educating health professionals. How do we educate? Because the reason for the late diagnosis is education, awareness, lack of awareness, and lack of education. This is what they have put it. Same study was, again, a similar survey was done by NCPOD, improving. They also included the hospital care and etc. But as a primary care doctor, this is the study. I was involved in this as well. Again, same question. They put it for the women. They all showed that the first appearance of symptoms presenting to GP was 4 years, and multiple visits to general practitioner. And we all have this nothing everywhere in Europe, everywhere, all of this is something, we have to really, is always this slide, sadly, I'm showing for many years. I'm hoping the number will change soon at some point. But one thing over the course, I'm actually with this course of the endometriosis since I joined my first patient in my gynecology was in the theater was a chocolate cyst when my professor was doing. I had no clue what it was. She shouted at me and she said, you should go home and read. Since that is the day, 1983, I was actually hooked up to endometriosis. And I'm also actually following the pathway of this. And one thing I can say in England, what changed is the Guardian article. After the Guardian article, it was published and so many people, and the media came out, the more the media came out, one is there are disadvantages, but the media, there is an advantage, people started talking about their condition and everything. Then what happened was, then a parliament also took a notice of that. They did another report, all party parliamentary group. They did a survey, that is just before the COVID they did. And what did they found? There was about 13,000 responses they got. What did they found again? They found again same thing. 58% visited GP over 10 times. And, frequent A&E attenders, 43 visited hospitals over 5 times. So these are the studies are showing, yes, it's not being diagnosed. What is the reason for that? So as a GP, I just want to share some of the things, and we also know that the survey also showed that how much impact it had on the mental health and also the well-being. 95% impacted the mental thing. And we know that endometriosis, like a peritoneal or ovarian, it can spread anywhere except the spleen, as far as I know. But everywhere it can spread. Another condition is adenomyosis, which is within the uterus it can be. And as we can see this is the endometriosis part. Within the muscles, it's called adenomyosis. It can spread everywhere. So this is outside. The endometrium is present. The lining of the womb is outside the womb. So it responds to the hormones. And surprisingly, we all think that it stops at menopause. But many postmenopausal women are taking HRT. And they're coming with a pain. So we have to change the HRT. That's a different topic by itself. But women after menopause also, they are suffering if they start taking only estrogen therapy as well. So this I have seen as well in my experience. So all these are just pictures, superficial, the deep. This is the chocolate cyst. This is the first one. This is one thing which I saw first time in 42 years ago. And we all know the classic endometriosis symptoms: pain with intercourse, pain, heavy periods, and infertility, painful bowel movements, pain passing urine, and fatigue is a very important symptom. So the GP should be a good listener, And the risk factors, we know that nulliparous, the more frequent cycles the woman has, the more risk it is. So if she has a prolonged period, heavy period, she's more at risk. So these are the risk factors. And I'm not going into the details of this because the research is being done now about the genetic and immunological thing. And then what happened after all this thing, when the article came, then NICE took interest and they published the thing. And after NICE has published the data, the education of the doctors has improved, definitely, especially the trainees, GP trainees. The Royal Colleges are interested, Royal College of Obstetricians, Royal College of General Practitioners, they have put in a lot of effort to educate the trainees. Okay, but still, it's still a lot more to do. So this is what the NICE brought. If there is any pain, think about endometriosis. So the European study, the human reproductive, ESHRE, they also did do a lot of, and they updated as well. And they focused more on the endometriosis happening in teenagers. So awareness should start right from the school education, when they talk, it's called as menstrual health in schools. So I had to do some guest lectures for school health nurses in the past, to help to identify the condition. So always again, same the problem. It is a repeat clinic, but a good history. The GP should have time to listen to the patient. That is what is very important. And take the history. What has happened? What happened? Anyone has in your family has this problem. So, and what happens to your bowel movements? How is your sexual life? And the GP should also have a time to the general examination. They may not do it. At least they should do an abdomen palpation, see whether it's tender or not. Sometimes on internal examination, some people don't even want to have a smear because it's so painful. And that should alert the nurse and the GP to say, why is she in a lot of pain? That should make them to think, are we missing endometriosis? Are we missing a condition which should be diagnosed? So that's very, very important. So it could be a painful condition or sometimes the women may not have baby, is trying for pregnancy, it's not happening, and the examination is normal. As Stacey has already put it in her presentation, it could be a varied presentation. So clinical examinations also is maybe absolutely normal. And we know the vaginal scan. I'm an ultrasonographer as well. So I do a lot of scans. The only thing we can diagnose is like, ovarian, if there's a big chocolate cyst to this. A negative scan could be there. Oh, I have pain, but the scan is negative. Okay, all these biomarkers are there, and I'm sure more and more research comes. And it's always a differential diagnosis. I'm going to concentrate about the reasons for delayed diagnosis. Low incidence of suspicion. So nobody, unless what the brain knows, then only we can diagnose the condition. Okay, so low incidence, nobody thinks about it. Overlapping symptoms. This is one thing I've diagrammed out to say. The uterus is in the center, in front is the bladder, and behind is the bowel. So the symptoms, the whole pelvis is just together. So many young girls, they will be told that is an irritable bowel syndrome. But at the same time, the GP or the doctor or the nurse who's asking, what about your periods? Is it related to the periods? That's very, very important. And the bladder is in front and it mimics pain, pelvic pain. They think it could be bladder. That's why many women are sent just giving antibiotics in this. Cultural attitudes, because they don't want to talk about menstrual. And the most important thing, which I become a little bit emotional talking about this, is normalizing painful menstruation. If a person has a pain due passing urine, they take it very serious. Opening bowels pain, oh my God, they take it very serious. Why a physiological condition like a menstruation should be more painful? Why should it stop them not going to work or to the school? So normalizing a painful menstruation is the cause of the delayed diagnosis. And often is dismissed. The more frequent attenders, they say it's up there. They think it's a psychological depression, stress, inadequate use of diagnostic tools as well, because we don't have the perfect tests as well. So this is the main cause for this, for the delayed diagnosis. So they can be the main diagnosis by laparoscopy, histological verification. But what can a primary care doctor do? Okay, and also, as we also know, the mild endometriosis can have more symptoms, and a severe endometriosis and already damage done may not have symptoms, pain symptoms as well. They may see at the time of fertility. But what I want to say is pain relief is the main thing, patient-centered. And I'll just go back to this. One important thing is, I will just show you. One important thing is a busy doctor, has no time at all, as a GP, but 10 minutes. This is what I do for presentation for all the GPs. Only you have 10 minutes. In this 10 minutes, what you can do is, I created a slide called 3 Ps for GPs. So when a patient comes with a pain, ask more history of pain, painful periods, painful sex, pain opening bowels, think about endometriosis, suspect endometriosis if she at the presentation. Never ever leave the patient without giving a prescription. So there comes as what is called as the mild painkiller, a paracetamol or whatever it is, and then if you're already taking painkillers, you discuss about non-steroidal anti-inflammatories. And if it's not good, go for it. Go through the pain ladder. Don't let her go without a painkiller. If the pain, sometimes the endometrial spots can be very close, pressing the nerves. And some women have a sharp pain. They'll describe the pain as if a knife is being turned inside. So that pain may not go with paracetamol. They need special medications for neuropathic, like SSRIs and TCA, pregabalin, like that. So pain is the most important thing. And the second thing is stopping the periods. When the woman is taking a cyclical combined pill, ask her not to have. The less period she has, the better it is. So that a GP can do. Okay. And then, of course, this busy doctor, 10 minutes. Another thing is painkillers and hormones, so don't let them go. And the third thing is, after you give everything to the patient, still she's in a lot of problems, have a low threshold. Don't think about it. Just refer them to the secondary care. That is the early diagnosis. So 3 Ps, GPs, this is the slide I tell. I'm a GP trainer as well. Wherever I go, I train the GPs to look at it. Sometimes I'm very happy to receive emails. We followed that and we diagnosed endometriosis. So this is the presentation. You don't have a time. The GP doesn't have a time. Just give a painkiller. Give them the website. She will come back and ask her to make another appointment. And the patient herself will say, yes, Dr. Marty. And there's a lot of information on the endometriosis. They have a tool, how to put the symptoms, and they can come back to you. So, and the most important thing in the primary care is it's a holistic care they need, because the patients are depressed and all. So this education is very, very important. Pain relief, psychological psychotherapy, about the dietary, and some of them is a chronic disease. And so it is, I'm glad, with this many years ago, it has been approved as a chronic disease. And now there is a lot of support, financial support, and med3 forms, giving them sick note. The patients should not hesitate this. So, and main important thing is the all parliamentary group, they're saying that we should be able to reach, I don't think it's a 4 years unless by 2025, it's a dream. And at least by 2030, we should make it. But most important thing is awareness and education, not to normalize the normal period, what a normal period is, and why it's, when it is painful, should take it serious. So these two, I'm just finishing my thing. Awareness in the public, definitely the awareness has gone up. I know for the last 15 years, I've seen so much is happening, and posters and social media. Raise awareness in the healthcare professionals, common condition, and involving the Royal College. And I'm also involved in doing the module for RCGP as well. We did one module. So it is now they're getting questions about endometriosis. I'm glad to know that in the exams, they're talking about endometriosis. So this is, as a primary care doctor, I just want the awareness in the doctors should be, in medical team, in medical professionals should be more and more, and hoping in future we will be able to diagnose early, treat efficiently, and prevent recurrence. Thank you very much for listening to me. Thank you.
Thank you very much, Uma. Yes, I mean, so much of what you said about what it is that GPs should be looking out for. You can't quite imagine why often they don't, and why people are dismissed for so long and after so many appointments when they have such severe symptoms. But that's an issue we're still battling with. Okay, so there are some questions in the chat which I hope we can get through to, and so I hope that we're able to tackle most of them in the time that we have. I thought actually maybe Jenny, if you don't mind, whether you have any thoughts about the presentations from that we've just heard in terms of how things have moved on since your experiences.
Yeah, it's definitely moved on compared to obviously when it happened to me, over 25 years ago from the start. It's been taken a bit more seriously. Obviously, we're still trying to, get that word out there about endometriosis and the taboo of it all. Like, it only affects you when when you're on your period, and especially about the menopause, how it can still affect, because I've had a total hysterectomy, and it's definitely obviously still there, and I'm still having symptoms again, and I'm trying to be taken seriously again regarding this, and it is still such a hard thing to do, to try and get it across to some NHS professionals who aren't as well educated on endometriosis. And that's what I think we need to try and do, because we are still being dismissed at times, some of us, even when we have had the diagnosis and it could have spread. But yeah, from when I was first diagnosed, it has come a little bit more, but it's like in different areas. It can be great in a few miles away from me, whereas where I'm located, it could be really poor, and I'm still having them issues like I am at the moment.
Yes, it is. It's very, very patchy depending on where you are and what hospital you might be being treated at. I mean, I don't know. Perhaps Uma, if you have anything to say about that variability.
Yes. Yeah, definitely. This is a very interesting, because I'm involved in HRT menopause clinic as well. Women with endometriosis, especially, they can't have just estrogen sometimes, because once there is no uterus, people don't give progesterone. Okay, when they know uterus. So if you have women who had endometriosis, there will be spots, there may be some spots outside the thing. So if she gets only estrogen, that will be activated. So it is, the education of the doctors is very, very important, at least for the first 1 year. I'm sure someone like Jenny will be benefited having a combined patch, both estrogen and progesterone. So what happens is, then the endometriosis will be very quiet. Okay, at least for the first 1 year, the studies have shown that we should give both estrogen and progesterone. So once there is no uterus, the doctors think there is no need for progesterone, but endometriosis is different. They still need progesterone. And there are new medications have come as well to take away the pain. So that is another important thing, you know. So someone like that education is very, very important for the GPs. Yeah.
Thank you. And Stacey, as well, in terms of you know, what's happening at a sort of clinical level, do you see how the research is filtering through to that, so it sort of improves the experiences that?
So I think a huge advancement, and you know, the program that's been put together today is so lovely because Lydia Coxon and Lucy Whitaker and there others will be speaking later who are actual pain experts. I will say that you know, my reaction as, you know, a teen whose pain was dismissed, and knowing that, you know, now as a postmenopausal woman whose pain gets dismissed, that the short answer is, if there's pain still being experienced, if there's life impact of symptoms, it matters. And so the just writ large, a response of, oh, but you've had a hysterectomy, oh, but you don't have endometriosis anymore, is absolutely invalid. The point is that people are still experiencing life impacting symptoms, and those symptoms should be addressed. And so from the research standpoint, where that has really, again, being very optimistic, where it has really leapt forward, is that there is a intense increase in the interconnectedness of pain experts, along with gynecologists and endometriosis specific experts, who are now working together to think about where we don't get training specifically focusing on endometriosis, actually in really nuanced pain pathways, nor in the scientific study design that's specific to pain. And so bringing those experts in, having an increase, you know, there's an international association for the study of pain. It did not have any pelvic pain focus until Katie Vincent and Frank Tu and some others in the endometriosis space really pushed that. And so that is improving. But again, that stay in your lane of bringing all expertise to now include essentially pain experts in both the clinical setting, but also in the research setting.
Okay, no, thank you. Thanks for that. Okay, let's move on to the questions, because there are actually quite a few. They're building up now. Hopefully the first one is a quick answer. It's to you, Jenny. I think at the start when you were giving your presentation, you talked about a scan, and someone has asked, what scan did you have?
It was the transvaginal ultrasound where they found it.
Okay, ultrasound. Thank you. Okay. Right, okay. The next one, I had a question about fluid in the pouch of Douglas. Is this a condition commonly seen in endometriosis patients, and what are the reasons behind it and the symptoms associated with it? Whether Uma or Stacey is able to talk about.
Yeah. Go ahead, Uma.
Okay. Fluid in the pouch of Douglas is mainly due to inflammation. It could be like a pelvic inflammatory disease or anything like this. And that it can change as well, you know, that it is a sign of inflammation, you know, and when there is a fluid or anything in the pouch of Douglas, some amount of fluid is normal physiologically. If it is more, or if there is any blood or anything, that will irritate the peritoneum and the patient will have more pain.
Okay.
So that it has a significance. I'm sure Stacey will be agree with that.
Yeah, I'll say we've done a few studies looking, because for scientific reasons we collect peritoneal fluid at the surgeries, and there is very varied volume at surgery of collecting and very varied appearance. And we've started to do some studies looking at, could we predict, like, was it the time of the menstrual cycle for those still cycling? Was there a difference between those who've had a hysterectomy and haven't? Was there differences of what medications they were on, diet differences, body size differences, those things? And so far, we've not found really definitively informative, defining like what is influencing the volume of the fluid outside of exactly as Dr. Mathi was just describing, really like known conditions response. So that's still early days in understanding. And I will say that this comes back to also a very general theme that I'm hopeful that we are drawing more and more attention and excitement, is that we have been offensively uncurious about the female body. And so, for example, to this question, we actually don't know what we know that there's difference among patients in terms of the volume of this type of fluid, but there's lots of things. We know that there's differences among patients in, you know, who experiences menstrual cramping and who doesn't, for example. But we really don't understand the underlying biology, anatomy, what's driving that diversity. And so foundationally, we have to insist on being more excited and interested in better understanding of the female body across the life course.
Okay, thank you. There's a question about the sort of permanence of nerve damage. Can endometriosis cause permanent nerve damage even after laparoscopic treatment and the removal of endometriosis? This person has had 2 surgeries and is still, sorry, the question's jumped, suffering the effects of suffering the effects with persistent chronic back pain that resumed a month or so after both surgeries.
So one thing, there's a different, I will certainly defer to Dr. Marthy's expertise here, that I will say from both a scientist and also biologic point of view, there is a set of what we refer to as chronic overlapping pain conditions. And there are currently defined 10 of those. Endometriosis is one, back pain is one. And so it is common to see patients with one of these chronic overlapping pain conditions also experience other conditions. So having endometriosis associated pain in tandem with back pain is common, and we need to do more to understand what is driving that commonality. Also, we're learning more, and Dr. Coxon and others are going to be speaking later in the day about pain specific to the endometriosis lesions themselves versus what we call nociplastic or centralized pain, which is the increased sensitivity to pain across the entire body, widespread pain. And so that is something that may be coming in play that's different necessarily from direct damage of a individual nerve by the lesion.
I think I agree. There could be initially there could be an irritation of the nerve, but I think the pain consultants will be able to tell us more about it. And usually women with endometriosis, as they have generalized pains as well. Is a lot of overlapping pain is also present in them. As a GP, I see quite a lot of patients with fatigue and a constant pain as well. So I think I'm not an expert in the pain as such, but I'm sure that will be addressed by the pain consultants as well. Never seen any permanent damage per se in my general practice with endometriosis, but I'm not an expert on that. Thank you.
Okay. Thank you. Okay, the next point, also, hopefully it's a fairly quick answer. This is from Sarah Bundy, and I acknowledge your comments about the impact that endometriosis has had on your life, and I'm sorry to hear that. But your question is it safe to take a GnRH analog like Zoladox on a long-term basis?
Do you want me to answer that? Yeah.
Yes,
the surprising thing is GnRH analogs have changed now a lot, because we normally GnRH analogs they give only for 6 years, 6 months, and maximum up to 12 months, because the reason is they can make the bones very thin. But it's a revolutionary thing has happened now. We have oral GnRH antagonists. So these tablets are actually some of them preparations, they have HRT with them. So a woman can take just one tablet, which has a GnRH analog as well as the HRT. What does the GnRH do is it suppresses the hormones in the pituitary level and it creates a menopausal state. So women will have severe side effects if they take only GnRH, like Zoladex or anything like that. So in such situation, we usually give them add back HRT. But now with the new medications, I'm actually quite hoping, because our NICE guideline, there is the NICE has approved those medications for management of pain in endometriosis. I'm sure we'll hear more about them in the next few lectures. So long term, GnRH is not recommended until unless they have HRT together.
Okay, thank you for that. Thank you. Next, so there's a handful of questions which are about education of medics. So I'm going to kind of group them together because we have so many questions. But there's one about how much information GPs had through their training, and then there's what could we do to improve endometriosis education in medical school. So I wonder, perhaps both Uma and Stacey, if you can say something about what's happening now and whether there are likely to be sort of changes afoot in that.
So I'll say and as I noted, one of the questions called out, it's inconsistent from one, and it really does depend on where the training occurs, and even like not just at a country level, but at a individual institution level. And I'll say from the US perspective, there's actually very little endometriosis and pelvic pain training. And part of that is because all medical students in the US take the same exams at the end of their training to certify for their degree. And most of the programs prioritize their time on teaching to things that are going to end up on the exam. And endometriosis and pelvic pain don't end up on the exam. And so it comes back to who's in the room at these many levels, that there are not typically gynecologists, for example, on the and pain experts on the board that sets the exams. So thinking about the curriculum, but also post-training Endometriosis UK and other groups, part of their initiatives are developing and targeting those educational things, trying to influence medical education, but then also for those GPs who are already in practice, trying to influence. But unfortunately, as has been present in the chat questions, it is not unusual for a patient to see a clinician who either doesn't know about endometriosis or what they know is very outdated and ineffective. Uma, as a clinician, so that's from my science and training lens, but as a clinician, you have so much more expertise here.
I'm not expert, but I'm a GP trainer as well. I have a lot of good news now, actually. Our CTP is taking it very serious. They have created a module. And if you see the MCQs questions, definitely there'll be a couple of questions on endometriosis. And also they do role play in the exams, in the main exam, in the member of Royal College of General Practitioners. Pelvic pain is being included in that. And quite a change I could see in the last about 5-6 years. Okay, and we have a lot of educational activities for the trainees as well as for the GPs, and most of the time they're bringing out this topic as chronic pelvic pain into the topic. So definitely the awareness has gone up and trainees are getting more and more into it, but still there is a room for a lot of improvement. Actually, I'm going the next week, this whole month of July, I'm doing 6 lectures all over England just on endometriosis for trainees and GPs, So because before I was not given the opportunity, but now I feel good that people asking me to talk about it. So that will help, So thank you.
Yeah, that's very encouraging to hear. So let's hope there's more, and you'll be super busy running all over the country doing training.
I don't mind.
Great. Okay. A question, I think this one's probably for you, Stacey, from Catherine Witcher. I've heard that endometriosis makes its own estrogen. Is there any evidence of this?
So there is a local estrogenic milieu difference in proximal to lesions in those with endometriosis relative to those without. There also are estrogen receptors and progesterone receptors and other differences from lesion to lesion within the same patient, across the patients. And my short answer is we're really early days in defining what is consistent across patients with endometriosis, what differs among them, what differs again from one tissue to another. And so basically a watch this space answer.
Okay, thanks. I'm not surprised that it's one that there isn't a firm answer to at this stage. What was I going to say? Oh, yes. So the question about combined oral contraceptive taken without a break. What's the guidance for its use in the long term? I guess, Uma, this is one for you.
You know, in England, we have these UK medical guidelines. So once the woman is suitable to have a pill, they have changed that guidelines, because before they used to take like 3 weeks and stop, so that the woman is allowed to bleed. But nowadays, the guideline is the women can take back-to-back the pill for 3 months. You can ask me why only 3 months? Because they found that if they take back-to-back for 3 months, they're less likely to have a breakthrough bleeding. If they're taking longer, there's a more chance of them having breakthrough bleeding. You know, that is why they say 3 months. But in spite of this, in some women, they can take only for 2 months back to back. And the third month, they may have a little bit of bleed. So basically, the amount of loss will be less. And if the woman takes continuously combined pill, and there'll be less periods. So less number of periods, less chance of regurgitation or activity of that can happen. And taking both estrogen and progesterone for a long time actually make the endometriotic areas quieter. That is the thing about it. And also it's a convenient phase as well. You know, before, like when they want to go on holiday or something, they'll just continue on that. So it is for convenient. So the UK guidelines now have come to take back-to-back pill for 3 months. Yeah. So most of the pills are now like that. Thank you.
Okay, great. Thank you. There's a question here about infertility. It was mentioned that endometriosis is one of the main causes of infertility, 30 to 50%. Assuming this means that endos causes 30 to 50% of infertility cases, what is the likelihood of someone being infertile or experiencing infertility issues if they have endometriosis? And I don't know how the figures correlate between general.
I'll jump in and say, so all of the data that we have so far, and again, these is information only from those patients who both are have their endometriosis successfully diagnosed and also have their infertility recognized. And so with that caveat, the data now suggests that about a third, 1 in 3 women with endometriosis will experience infertility and fertility issues. We currently, and this is one of the things that many of these collaborative groups are working on, we don't have a way of predicting who among those with endometriosis will have fertility issues. So again, the short answer is that the majority of patients present with pain, not with infertility, but about 1 in 3 will experience infertility. So it's another thing to be conscious of. And one of the things that we do disservice to is that by not knowing how to predict, it does change how those with endometriosis think about their future planning. Also, this is a place of great geographic, financial, economic, social disparity, because we know that the majority of people do not actually have access to fertility care. And so also who gets defined as experiencing infertility, who can access care, who can think about their life course family planning is a very privileged position. And we're currently only capturing information, or most of the information we're capturing is only in those privileged groups as defined in many ways.
Okay. We may have just one more question I think I have time for. There was a question about scarring, which just jumped away from me. Sorry, lost it. Yes, the causes for what causes scarring in endometriosis. Is this the lesions bleeding, or just the presence of the lesions alone that causes an immune response?
Well, I will say from the science side, and then that I'm very interested in Dr. Marthy's clinical expertise and experience, is that this is a fascinating area where we know there's huge differences among patients of who develops large-scale scarring and adhesions and who doesn't. And so the genetic data that I just touched on a little bit, where we are definitely seeing differences, we see these differences in the presence or absence of endometrioma among patients in terms of the genes that we're exploring. We see differences in the ASRM staging of stage 3-4 versus stage 1-2. Now, stage 3-4 is defined in part by the presence of endometrioma or not, but it's also defined by the presence and the extent of scarring and adhesions. The hard part is that the extent of scarring and adhesions is not something that's clinically documented. And so it's one of the things where with the Effect surgical tool, we are collecting that information. And so combining that information across the sites across the globe is just starting to give us the numbers to look at that. But we expect that there are differences among patients. And because of that, so all of the patients have endometriosis lesion tissue that is responding to the menstrual cycle for those who are still menstruating or who are not on suppressing hormones. And that does play a role in the scarring and adhesions, but that absolutely does not define who has really extensive scarring and adhesions, who doesn't. There are other biologic factors that we still don't understand. Uma, I'm sure you see such diversity in your patients.
Yes, definitely. I've seen patients when they went, no other symptoms, just for infertility, went to for a laparoscopy as a part of investigation, and they found it's all like a frozen pelvis with endometriosis and the scarring. And she said, oh, I had only occasional painful periods or something like that. And I've seen the other side of the patients who are in a lot of pain where there'll be minimal peritoneal thing. So it is quite a fascinating to know that there is no clinical correlation with the damage that happens to the tubes or in the pelvis with the symptoms as well. So it is that is one thing with the endometriosis is a cause of the late diagnosis as well. That's the one thing as well.
Yeah, no, thank you for that. I think that will have to be the last question, and I think your answer to that just show, the complexity of the condition and still how much more work there is to do to understand all of those variabilities. Sorry, we had a lot of questions. I know some of them are being answered within the chat, so please look out for an answer to your question if we didn't actually cover it. But I will end my part of today's event here, and thank you very much to Uma, Stacey, and to Jenny. And I'll hand over to Emma.
Thank you, Catherine, and again, thank you, Jenny, Uma, and Stacey. Great to hear your stories and your experiences as well. So our first section, as you've just heard, was on getting a diagnosis. And what we're moving on to now, and I realise we've only scratched the surface of getting a diagnosis, but we have a limited time. So what we're going to move on to now is we're going to be talking about managing and treating endometriosis. And then the final section towards the end of the day is going to be about endometriosis-related pain. So we're going to hear, first of all, from three people with experts by experience. So I'm going to welcome Lexi, Shella, and Britt to join me, if that's okay. And we're going to start off with Shella. Sorry, Lexi. Oh. Hello, Lexi. I haven't seen you for a while. Hi, Lexi. I hope things are good in Birmingham. So, Lexi, would you like to kick off by talking to us about living endometriosis and associated fertility challenges?
Yes, thanks, Emma, and thanks everyone for your time today. So I'm just going to talk a little bit about my experience, just to caveat that this is obviously just my experience, so it may be different for each individual, and I'm going to try and talk the honest and open experiences that I've had. So just a bit of background, I was diagnosed at 24 with stage 4 deep infiltrating endometriosis. Every organ within my pelvic area was fused together. I have had 5 surgeries to date, and another one planned in the future. However, that is currently on pause because of the fertility journey that I'm going through. So, as a lot of us, that when we find out eventually that we have endometriosis, you have a look and you try to familiarize yourself with what this now means. And it's glaringly obvious in a lot of the things that you read that your fertility can be impacted. Even if you Google infertility and look on the NHS website, it's listed in the 4 or 5 main causes for infertility in women and those assigned female at birth. So I was quite shocked when I started talking to my GP, my consultant, about looking at starting a family and what that would mean for me, to hear that there was very little or no support offered around this conversation. Very early into my conversations with my consultant, he made it quite clear that actually my chances of conceiving naturally were going to be very slim. And there is, however, this dreaded phrase, and a lot of the support group that I have the privilege of meeting with regularly hear this phrase when you're diagnosed with endometriosis about, well, you should really start thinking about having a family soon, which blows my mind on the fact that they're linked to infertility, yet that's some of the advice that we're told to start exploring. So I took this advice and started having a look to see what was available to me, what I could do, what were the options. And it became quite clear very quickly through conversations with my consultant that the best route for me, if it wasn't happening naturally, within kind of 3 to 6 months of trying, was going to be IVF. So 3 to 6 months doesn't sound particularly excessive, but again, part of my symptoms for endometriosis was real pain during intercourse, certainly during and then after, doesn't really leave you in the mood for trying to create a new life. So that in itself was already a challenge and an internal mental, emotional battle to get through. But my partner and I persevered. And nothing was happening. So my consultant created a letter that was sent to my GP about getting us referred. Now, again, there's not a huge amount of information around what the IVF journey looks like, but I found it a real challenge. I was met with resistance from GPs as to, well, actually, it needs to be 2 years that you're trying, rather than taking into consideration the history, the number of surgeries, all of these things that were happening. The letter from my consultant didn't seem to be enough. And the realization again that even if I was referred for IVF, because of my postcode, and I think it was Stacey, my apologies if it wasn't you, that mentioned kind of that element of privilege that comes with being able to access these things. Within my postcode area, I was able to have 1 round of IVF funded by the NHS. That was it. But I also had no choice in terms of where that was taking place. There is 1 clinic available to me, and that is it. So if I don't like it, then I have the option to go privately and pay. I have a number of friends and a number of people through and the support groups that have had to look at options for fertility treatment, and it's already thousands of pounds for something that we all know is not guaranteed. So for me, I had to, excuse the pun, put all my eggs in one basket and go down the route with this particular clinic. After many a conversation with my GP, after fighting and advocating, after my partner doing exactly the same for us to get that referral, and me being quite frank and saying, how do you know I haven't been trying for 2 years? Write it down, because unless you're coming home with us, we'll just take that as that's going to be the box that is ticked. Great, we'll do that. But my experience with the clinic has been phenomenal. They have been really understanding, far more supportive, but they did explain I suppose the expectations around IVF. There is no guarantee. They tell you the science about this. They offer counselling services, which if anybody is looking at going down this journey, I strongly advise taking advantage, because you can't explain to anybody. There isn't the words to appreciate the feeling of this journey and what this looks like. And it's even more difficult, or I certainly found it, when in order to get those initial results, even through your GP, women have to pay for their AMH results. If I had to pay £100 to get that blood test, my partner, nothing. He could pop into his room, do what he needed to do, and he got a full list, A4 piece of paper, of all the wonderful things that his sperm is doing. And I paid £100 for 2 lines of table that gave me an AMH result. So you already feel that you're at a disadvantage. You then go into this process with the guilt that you're the problem, and that's quite a difficult thing to navigate. And I think if I hadn't had such a wonderful clinic and the support that they offered, this could have been even more of a traumatic journey. Conscious of time, but to round things up, this is still not an easy process. Because of my endometriosis, we started with 6 cancelled IVF cycles because we couldn't get my lining to where it needed to be. I was referred back to the NHS to have a hysteroscopy because the clinic were concerned about the lining and why this wasn't growing. Due to the NHS waiting lists, that was looking to be 18 months to 2 years before I had that hysteroscopy. So we then had to make the decision: do we pay privately and use the money we have aside for a potential second round of IVF if this doesn't work, and have the hysteroscopy through a private practice? Or do we sit and wait, knowing that I'm already 37 and I have lots of other things against me and things are getting worse? We made the decision to pay. So I had that surgery at the back end of last year, and we are going through the motions now. But this is a constant battle, and it is incredibly difficult a journey to go through for anybody that goes through fertility, let alone with having to advocate and deal with the wonderful demons that endometriosis throws your way. So trying to find a positive from this, I'm incredibly lucky that I have a fantastic clinic and a great support network through our Birmingham and Black Country support group, who are always there, and of course through the wonderful resources that Endometriosis UK have. But this is not for the faint-hearted. And I wish anybody that's going through this journey the best of luck.
Lexi, thank you for sharing what I know is a challenging and difficult story, and I wish you all the best of luck. For those of you listening, especially the GPs around, it actually, under the IVF NICE guidelines, it is very clear that if somebody has a known reason for infertility, including endometriosis, they do not have to wait 2 years of trying to go through the NICE guidelines state they should be referred immediately to fertility. And whilst fertility does impact on endometriosis, it's up to 70% of those with the disease will get pregnant naturally. So as Lexi said, it's a very personal story. And Lexi, I do thank you very much for sharing that. We're going to move on to hear Shella, who also is going to share her experience. Shella, if you'd like to come online, I think I've seen you. Here we go. And Shella is going to talk to us, thank you, about just briefly about your experience with pain. Thank you, Shella.
Hi, thank you, Emma. So my name is Shella. I am a support group leader for Derby, which has been on pause for a while because I am struggling a lot myself. So just a little bit of background history about myself. From the age of 12, my periods were not normal. I was bleeding really heavy. I was missing a week of school every month. I was fainting, I was vomiting, I was putting on so much weight, I wasn't understanding what was going on. My mum's English wasn't her first language, so she was struggling to take me to the GP. She would take me, they said there's nothing wrong, she'll be fine, it's just because she started, just let it run its course and she should be okay. By the time I was like sort of 15, 16, my periods started getting worse. So there was a lot of education getting missed. But we just kept going back and forth, and the GP saying the exact same thing. So at 17, they referred me to gastroenterology. They said that you've got IBS because at that point I started losing a lot of weight unintentionally, but I think it was more the pain because I was in severe pain. I then went to see gastroenterology. They just said you've got IBS, so they put me on like a FODMAP diet. They put me on everything, but the pain was still there, and I was trying to explain the pain is like lowered down. No one was having it. At 21, I started working with out of hours in Derby, and I still remember it is very vividly. I was finishing work after a 12-hour shift, and I was like waiting to get home because I was like, I feel like I'm going to start my period, and I know when I'm about to start, so I get like in 10 days in advance. Well, that was before, but now I'm constantly in pain, so I would get sick, I would feel like I was going to vomit, and I would get really, really hot. And I just said to the GPs, I said, if I do faint and I pass out and I'm sick, it's pretty normal. It's my period coming. I just need to get home. And they all just looked at me strangely. They were like, what do you mean? And I said, it's normal because my GPs and everyone has told me it's pretty normal for you. And that's not normal. I was like, it is normal for me, because I was under the impression it was normal for me. They didn't let me go home. They sent me to A&E. I went to A&E. They just said, oh, it's your period, so I don't know what you're here for. Go home, see your GP. At which point the GPs I was working with rang in and emailed my actual GP, and all of a sudden I got a call to say you need to come to see us. I went to see them. They said we're referring to gynecology. We feel like you've got a condition called endometriosis. It was all brand new to me, didn't know what that was. Seeing gynecology, this all happened very fast, so in the space of a few weeks. And then in the space of from May to June, I had my first laparoscopy surgery and then diagnosed endometriosis. And it's been like a really, really tough journey since. I've had 4 surgeries. I've had a bilateral nerve block, which completely failed. And I've been on every treatment possible that you could have for hormones. I've had the implant, the coil gave me pelvic inflammatory disease. I'm on a very small dose of norethindrone because norethindrone, what we've noticed, every hormonal treatment had an adverse effect on me. So instead of like helping me, so when I was in chemical menopause, which I've been put into 5 times, it would, instead of helping me stop my bleed and the pain, it would go the opposite way. So I would start bleeding even more heavily. And because I'm already anemic, it would cause my iron levels to drop, and that would cause me to faint even more than I would regularly. So now at the moment, I'm taking a very, very small dose of Noriday just to regulate my period so it comes like every 6 weeks. But the pain, I can't explain the pain. The pain is absolutely horrendous. It's like, it has taken a toll on me as a person. I feel like I'm not the person that I used to be. My weight fluctuates because I'm on hormones. So I've gone from like a size 8, I went to a size 14. It just, because of the hormones, that then started taking a toll on your mental health. And no one, there wasn't that support, and that was happening a lot through COVID. And I appreciate it was COVID, but there was no support. And then I joined Endometriosis UK as a support group volunteer in, I think, 2019, just because I was so passionate about it. Because I was like, we can't speak on it. As an Asian female, we're not allowed to speak about our periods. We've been silenced really, to say it's not normal to speak about your periods, you just have to deal with it. And the comments that I get regularly is about, you should get married, you're getting on, you're 32, you're not married, but you can't get married and have a child when you're in so much pain. And that's what I have to explain. And it's like I'm fighting a losing battle with everybody. But because I was so passionate, I started joining a lot of research groups. So I do a lot of work with different research groups in helping like get endometriosis out there for women with ethnic minorities, especially because we don't speak on it because it's such a taboo subject for us. We're not allowed to speak on it. And I'm trying to be that voice for everybody to say, look, we can speak on it. We should speak on it. There's nothing to be ashamed of. It's part of life. But obviously that's looked up, frowned upon for doing that. but I'm very, very passionate, and I'm going to carry on doing what I'm doing because I feel like someone needs to do it. So I joined a Derby support group for that reason, and then it's obviously opened a lot of opportunities for me, which I'm super grateful for. But my own journey has been super difficult, and I don't want the further generations to come to go through the same thing I had to go through, or any lady for that matter of fact, because I just feel it's not fair. We need to be listened to. We were dismissed. Like just touching on one experience of going to A&E at one point. I went in, I was sick, I was vomiting, it was horrible. And one of the nurses turned around and said to me, "Oh, stop exaggerating, can't be that bad. It's just a period." I cried. I didn't know what to do, so I left. I was like, okay. And when I told my gynecologist, she was like, "Oh, I'm so sorry you made you feel like that." But I said, it's pretty normal. I've been feeling like this since I was the age of 12. I was dismissed constantly, not just because of through healthcare professionals, from family, from friends. So it made me become even more passionate. Like this fire in me was like, you need to do it. You need to do it for yourself, for your younger self, as well as the generations to come and women that have been silenced. So yeah, just touching up on that. The experience has been awful. Like, I know every lady has their own way, every sort of dealing with it and what they're going through. And I appreciate everyone's journey is not the same, but I would advise speak on it. Go to your GP as much as you can. Annoy them if you have to. Write a diary, write your symptoms, your triggers, write everything down, track your cycle, go to them, have the evidence, prove it to them, say, listen, you need to refer me to gynecology. Even if it comes out you haven't got endometriosis, you may have a PCOS or anything as such, but you've done what you need to do. But obviously, on average, it takes women to be diagnosed for 8 years. We want to do it quicker because it's not fair on us. And I'm trying to push that as well. And I hope, obviously, whoever's struggling out there, you've got a support network. You can reach out to anybody. We're here. And don't be like myself. Just don't be silent. And it does take a toll on your mental health. I know it does. It took a toll on my mental health as well as my work. So I had to give up my job. I'm grateful that I'm back into work. But again, it still does affect you, although people can't see you physically, like a physical.
Yeah. Shella, I'm afraid, I love hearing your story, and I'm sorry to interrupt, but in the need of timing, I think your real passion for advocating for others always comes through, and I'm really grateful, and thank you for your strong message. Stay on for the panel, and we'll pick up some of those topics as well. And then I'm going to hand over next to Britt, who's going to give us a brief, and I know Britt as well, this is going to be tough doing in a short time, but Britt, if you could give us your expert experience of living with daily management of endometriosis. Thank you.
Yes, of course. First off, thank you so much, everyone, for inviting me along today. Such a great opportunity to share my own perspective and also many others that I've heard throughout the years that echo what other patient advocates have said today. So in terms to give you guys context, I was diagnosed with endometriosis only 5 years ago, after well over a decade of trying to figure out what was the cause of my pain. From that, I've become a very passionate patient advocate, and I run the Glasgow Support Group for Endometriosis UK, and the network up here in Scotland. So in regards of daily management of my symptoms, I think it's really important to point out, as Lexi said, this looks different for everybody. So if you're a patient that's listening, please don't feel discouraged if you hear symptoms that I have and you don't, or vice versa. It can look different each day as well, which is really important. No 2 days are the same. So I try to, in the management of my symptoms, look at it from a holistic approach of all the things that I'm doing and working with my GP, how it's impacting me and how I can essentially have the best quality of life possible. So for me, some of the symptoms that I really struggle with and have continued to struggle with throughout my endometriosis journey have been severe flank, back, and leg pain, where my sciatic nerve is, stabbing ovary pain, endobelly, being extremely swollen and distended, quite severe cramping. Fatigue is a major one up there that has impacted that. And then obviously, the more fatigued I am, the more intense my pain is. So the things that to give you insight into how I manage it. Heat is a big part of that. I know that we have to regulate how often we're using heat and alternate that with cold, but I always have a heating pad. In fact, I'm sitting with my heating pad just now because I'm quite sore. I also do have painkillers, and that has changed throughout the year. So for my pain management at different stages, when I've been at my worst, I've been on nerve painkillers like gabapentin and pregabalin, and I've worked closely with my GP to regulate that to find the right dose, but they were very helpful at that time. I'm also worked with pain specialists to assess how I take my medication, but I appreciate that not everybody has access to that. So one of the things that I would recommend that I do to help with my symptom is to try to open that line of communication with your GP, your nurse practitioner, and I think, well, at least in Scotland, a lot of the GPs do have a surgery pharmacist. The surgery pharmacist was so incredibly helpful because as I try to manage my pain and these symptoms I'm experiencing, obviously trying to look at how you're taking your medication is a really important part of that. And, you know, the dosage is also a very important part, and understanding what are the side effects of that medication versus what are your symptoms of endometriosis. So that has really helped me manage my symptoms. Another big part of this is that for me, I work full time. I'm very lucky to work a hybrid, so I'm really only in the office maybe 1 or 2 days a week. But I've had to, because of my symptoms, I've had to become very aware of what I have at hand. And so I create what I call these endo go bags. And I do recommend it for anybody who has a chronic illness. It's basically got emergency medication for anything that I would need to take through the day, whether that be for mild pain or severe pain, just so I don't get caught out. I use BU patches, things like Tiger Balm and cold gel for that alternation, because I also take migraines with hormonal migraines with my endometriosis. I have portable heat patches in case I can't have my heating pad. And one of the big things that's really helped me manage my endometriosis and the stress and pressure that I have on myself is asking for accommodations at work. So for me, my brain fog and my pain is worse in the afternoon, and I'm at my best performance, shall we say, first thing in the morning. So I work from 7 to 4, and that's really allowed me to be more optimal within work. And it's also in place so that that's not something I'm having to constantly bring up. And equally, when I do have a really bad flare, it's within my accommodations that I can just message and say, I'm having a high pain flare day. I need to start later. Or I even say, I can't work today. I'll have to look to see how I am tomorrow. And that communication there has really helped me within my professional career, because I'm not having that pressure of having to constantly communicate, and it's recorded. So in a lot of ways, it also helps protect me in that way that's been agreed upon. I'm very aware of time, so I'll go ahead and wrap up. But one of the things I would also say is just having that open line of communication as much as you can with your GP, because with that, when they referred me to the pharmacist, there was a lot of different medications I necessarily weren't aware of. And this is a full span. It doesn't necessarily need to be nerve painkillers. It can be a wide variety. And working through that relationship of how I was taking things and how I balance everything with work and with just being a person was a huge importance, because it's all about finding that balance. So if you have the opportunity, I appreciate not everybody will have access to a pain specialist, but if you can start with your GP and ask to speak to the surgery pharmacist, that could be really helpful for your symptoms. It's definitely been a game changer for myself. So I think I'll probably be at 5 minutes. So I'll pass back over to you.
Thank you, Britt. That's some really helpful tips for people as well. So thank you for that. And I'm delighted next to hand over to Dr. Lucy Whitaker to talk about the challenges from a research perspective of precision care. Lucy, lovely to see you. Handing over to you.
Thanks very much, Emma. Can you see my slides?
I can.
Fantastic. The IT is working. Brilliant. Thanks to the RSM for all their support. So my name is Lucy Whitaker. I am a Senior Clinical Research Fellow at the University of Edinburgh, and I'm also a consultant gynaecologist. I work at the Royal Infirmary of Edinburgh, which is the South East Scotland BSG Centre for Complex Endometriosis. And I'm just going to talk really over the next 15 minutes about the research challenges and why it has been hard for us to get to more precision care for endometriosis. By that, I mean getting the right treatment for the right person at the right time. So these are my disclosures. And what I'm going to cover is really some of those challenges around us that face us in the research space, but also some more positive messages for the future, and particularly about some emerging research on new treatments for endometriosis and where also I see some of the future of endometriosis treatments. So let's start off with the challenges. And some of this is going to echo what we've already heard from those who are experts by experience, that whilst we've got the mainstay of our treatments are hormonal medication, surgical removal of lesions and pain management, but we know that whilst these work well for some people, none of these approaches will work for everybody, and they all have their downsides. So hormonal treatments can cause side effects such as unpredictable bleeding. They also can have other side effects such as impact on your bone density or mood. And they're typically contraceptives, which means for anyone trying to become pregnant, they're not an appropriate choice. And in terms of surgery, it carries risks. And we know that many individuals will have persistent pain or only short-term benefit from surgery, or in some cases, the worst case scenario, in that they get new pain after surgery. And the medical pain management, Britt spoke really eloquently how it can be incredibly helpful. But equally, I think we would acknowledge that some of the medications we use within pain management also have their side effects. And for strategies such as psychology, pain management programs and physiotherapy, whilst we know from the APPG report that these are desperately wanted by patients, there are issues with capacity and access to these types of care. And the NCPOD report that was referenced earlier by Uma about the issues about access to care, that also reported on patients' responses to treatment. There was over 2,000 responses into this survey. And this showed that 42% of people had no improvement with hormonal medication. And I think really devastating that only 17% of patients were satisfied with the results of their surgery. And I think one of the real concerns that was also highlighted with this report, that over nearly a third of patients were being prescribed opiates. And we've all seen the impact of the opiate crisis within America. So I guess the question is, for a condition that affects 1 in 10 women, so 1.5 billion in the UK alone, why aren't we managing it better? And if we put aside the issues of NHS capacity and challenges post-COVID, ultimately, if we want better treatments for endometriosis, we're going to need to understand the disease better. And this is really challenging. So as Stacey's alluded to already, it's a complex disease. It's not one single, very homogeneous condition. There's lots of different challenges to it. So we don't think it's now one condition. There's lots of different subtypes. So there's superficial peritoneal endometriosis, ovarian, deep, and also extrapelvic endometriosis. And she described very eloquently that the symptoms are very variable from individuals, some who have more predominantly period pain, others non-cyclical pain, and then others having factors such as bowel or bladder symptoms, as well as those more systemic features of fatigue. So if we've got very varied symptoms, how can we have treatments that are going to address all of these? And what's even more challenging is that disconnect between the presenting symptoms and the disease itself, as well as so the subtype of disease doesn't correlate well with the symptoms, but also the volume or location of disease doesn't correlate well. And equally, on the other end of the spectrum, we have some people who've had no particular pain, have had previous fertility and are attending for surgery to have their fallopian tubes ligated, are found to have very extensive lesions. So this disease is really complicated with that disconnect. Now, this disconnect is also even more complicated because we've got the impact of other conditions that frequently coexist with endometriosis. So things like heavy periods, adenomyosis, which I always think of as being cousin to endometriosis, but other conditions like IBS, fibromyalgia, and also some of the roles of different mechanisms of pain. And Lydia Coxon's going to be covering that in the next session. So as well as this disconnect between symptoms, different disease types, the symptoms also change a lot over time. Now, these can change very rapidly across the menstrual cycle. So we know that endometriosis lesions contain some of those same receptors that govern the menstrual cycle and the endometrium across it. And that as you get change in the levels of those hormones across the month, ultimately resulting in breakdown of the lining of the womb and being shed in the form of a period, you have a huge amount of inflammation associated with that. And we get that same inflammation within those lesions. So that's why for many patients, they have that very cyclical change in the symptoms. But we also know lots of people have non-cyclical symptoms or unpredictable affairs despite complete hormonal suppression, be that medically or surgically induced. We also know that factors such as stress, diet, and fatigue can also aggravate symptoms, suggesting that the etiology of pain or those symptoms of endometriosis is more complicated than just cyclical fluctuations in the sex hormones. And we know in other conditions which have flares such as IBS and bladder pain syndrome, the factors such as stress, change in the diet, and the type of bacteria in the gut and bladder are associated with flares. But what we don't really know is what their role is within endometriosis. And then alongside that kind of more acute changes in symptoms, as has already been really well articulated already today, particularly by Stacey, that symptoms can change over time within one individual, but also we get a change in the disease. So in some people, they can develop new lesions or they can develop other subtypes of disease. But we also know in some people, actually, those lesions will stay really stable in number, or in fact can resolve spontaneously on their own. And again, we don't understand the reasons for this. And then to further complicate all our challenges against the background of this disease, it's so complicated we don't fully understand. We also know the needs of an individual are going to change as they progress through their reproductive life course. So having one treatment that's going to fit all their needs at every time point is going to be near on impossible. So it's about having different options to offer people. But then when we're trying to understand the disease to be able to develop better treatments, the other thing that we're really hampered is that our models of endometriosis are really imperfect. So endometriosis lesions in themselves are really complicated. There's lots of different cell types. So you've got those cells similar to the lining of the womb, but you've also got lots of inflammatory cells. You've got lots of growth of new nerve fibers and blood fibers, and as well as lots of different processes about sort of the amount of oxygen, scarring, how the cells are dividing, as well as producing a lot of inflammatory chemicals and other steroids themselves. And it's almost impossible to reproduce this complexity in our cell culture systems in the laboratory. And our animal models don't fully reproduce the same disease process, as well as all the ethical issues that are associated with them. Now, this means that treatments that work in laboratory models often don't work in the same in humans. And this is such a barrier to bringing new and effective treatments in patients. So ideally, we'd rather work in women, but there's clearly limitations on the type of studies that we can do in patients. And also in keeping in with those challenges of diagnosis outlined in the first session, it's really hard for us to know what's happening over time in those lesions or in response to treatment because our methods of identifying and monitoring endometriosis are so imperfect. So again, this gives us an additional challenge of how to understand the effects of treatments on endometriosis within the context of clinical trials. And alongside that, within our clinical trials to date, often they're not big enough to explore those differences about different subtypes, and often certain demographics are overrepresented in our trials. And so the findings that we get from these studies aren't necessarily reflective of how these treatments are going to work in all of those affected by endometriosis. And then one of the big elephants in the room is about the money. And and for decades, women's health, including endometriosis, has had significantly less investment than other conditions. And I think this example from the States is a really good example. So the NIH in the US had an annual research budget in 2022 of over $41 billion. Now, Crohn's disease, which is a chronic inflammatory condition with often very severe symptoms, got $90 million. Now, Crohn's affects 0.2% of the population, so that equates to about $130 per person with Crohn's. Now, endometriosis, similar to Crohn's, is a lifelong complex inflammatory condition which can have severe impact on symptoms. It affects 5% of the population, but the funding for endometriosis was only $16 million. So that equates to $2 per person with endometriosis. And if we don't get the funding, it's incredibly hard for us to overcome these research challenges. So I've realized that everything I've said may sound a bit negative, but this is really why we are struggling to get rapidly to better treatments for endometriosis. But I think there is a lot of hope for future treatments, particularly as we take learning from other conditions. Now, if we consider breast cancer, we know how the power of research has improved treatments and outcomes. So as we've learned about the genetics and also particularly about the subtypes of disease, This has led to less radical surgical treatments and more sophisticated hormonal treatments. But really the key breakthroughs have been about understanding the biology. And this has led to more non-hormonal treatments and more recently the immunotherapies, which have had a staggering improvement in outcomes. So if we can apply the same theories in how we understand the biology as well as the investment in research, I think it's really hopeful for the future. And if we consider endometriosis, this, as we understand more about the condition and sort of moving away from particularly the steroid components and understanding the roles of proliferation and the inflammatory response, this has given us new treatment targets and new treatments that we can use. And so now over a third of the current clinical trials in action at present are assessing non-hormonal medical treatments as we learn to capitalize on this better understanding of all the different components of the endometriosis biology. And this is really the pathway that we've taken our research in Edinburgh. So we very much align ourselves to the Jameson's Alliance priorities, the top 10 priorities that Uma was describing. And then we have an incredibly engaged group of patients who offer us our samples when they undergo surgery or they donate their blood or their urine or their feces. And this has allowed us to really explore some of those patient-specific changes. We've also explored factors in flares, fatigue and activity levels, as well as the gut microbiome. And then we can go and take these patient-specific changes and targets for them, test them in our laboratory models, and then move those quickly into clinical trials for patients. And one of the examples I think is a really good example of this is our EPIC studies, where we're looking at lactate and targeting the production of it to treat endometriosis. And so from these differences that we identified in patients, we can then found a drug that we could target some of these changes, which worked really well in the laboratory. And then we've already taken this into an exploratory study in women's and now starting a larger trial later this year as a non-hormonal treatment for endometriosis. And I think it's really important that we offer patients options. I think we're also been really lucky about the funding we got to help support that work. But initially we had to go to charities for that funding before being able to move to bigger funders such as the Medical Research Council. So where are we going in the future?
One more minute, Lucy, if that's okay.
Oh, I thought I had 3.
Give me 2.
Talk quickly. Stacey's already talked about worth effect. I think that power of working together is really important to get more diverse studies that are also big enough to be able to identify the differences. And she's already alluded to the big genetic studies that have helped giving us some insight. But I think also genetics is really interesting when we start thinking about how different people might respond differently to drugs. And we already see this in things like stroke and diabetes. And I think we will be using this more in some of the medications we used in endometriosis. But I think also having slightly more novel approaches to endometriosis research, and one of the examples are Endo 1000 project, which we're doing in collaboration with Endometriosis UK, which is about, again, having these big bioresources, but also taking samples that have perhaps been less traditional. So looking at the microbiome, looking at feces, looking at urine, looking at stress, looking at fatigue and activity, as well as work to do on diagnostics to then be able to have more precision, personalised care for individuals. And I think the clinical trials, we're now much more aware that these need to be big, they need to have novel designs and delivery and be much more aware of the importance of subtypes and symptoms as well as genetics, as well as working really hard on the diversity. And I think we're really fortunate that we have highly engaged patient partners. It's an incredibly privileged position to work with all the endometriosis we work with, as well as the patient support organisations. And we are beginning to see from NIHR increased funding. They supported our surgical trial, which is looking at specifically at the superficial peritoneal subtype of endometriosis, as well as the current funding call for pain management programs. And so really where I see us moving to is instead of taking this one size fits all, where we take a history, we do an examination, then we make generalized recommendations really about hormones and then the role of surgery and anti-inflammatories. But actually we're going to have, firstly, a wider range of treatments to offer people, including the options of non-hormonal medical treatments. And what we'll be able to do is stratify our patients based both on their symptoms, their genetics and other factors, so that we can then help be able to subgroup our patients so that the right person is going to get the right treatment that's going to work for them early on, rather than working through a multitude of different treatments. So really just to summarize, recent reports have emphasised that the existing treatments are ineffective, which we've already heard so clearly articulated today. Endometriosis research is really challenging, and that inevitably impacts upon our ability to develop better treatments for endometriosis. But I think we're all much more aware now, particularly that through better understanding of this disease, it's going to lead to new hormone treatments, and there are already new treatments on the horizon, particularly those in the non-hormonal space. But it's very important that our studies are large enough and well profiled to be able to have better outcomes for all. And I think it's very much a team effort, and I would encourage everyone to be part of research, whether or not that's taking part in trials, to donating your tissue or blood at the time of surgery, so that we can all work together to improve outcomes in this condition. And thank you very much. This is all the team in Edinburgh.
Thank you, Lucy. Fascinating run through. I know that you could have told us a lot more. We'll look forward to hearing from you more in the future. But that was a great run through and some really interesting work. And do put questions you might have for Lucy or any of the other speakers in the Q&A. And then our last speaker of this session, can I hand over to Elsa, please? Elsa's around, as you can see you online, Elsa. I'm sure Elsa will be joining us shortly. Elsa is, oh, there we go, Elsa, thank you.
You see me?
Yes.
Trying to make sure this works. Okay.
That's good, Elsa. Thank you.
Can you see it now?
I can indeed.
Great. Okay. Thank you very much for the opportunity to speak. Moving me a bit out of my comfort zone. And so my topic is managing and treating endometriosis, practical considerations. So we've heard some of what I'll say will be similar to what you've heard before. So just make sure this is the first one. So the needs of the endometriosis patient, or the patient with endometriosis. And we know that the symptoms of endometriosis significantly affect women, both physically and mental, and in general, her whole well-being. It affects her quality of life, makes it less. For most women, the general health affects us emotionally, family life, working life, and intimate relations. So factors to consider prior to treatments are the symptoms, because everyone's symptoms, even though they may be the same pain, pelvic bleeding, they will differ for the individual. The age of the person, whether fertility is in their plan or not, how bad the disease is, and also where the disease is, because we've talked about the fact that the symptoms that women get doesn't necessarily correlate with how bad the disease is. And treatment of confirmed diseases usually go a number of ways. So it can be expectant management, which I'll go through, pain control, lifestyle changes, i.e. diet and exercise, hormonal treatment in the form of the combined contraceptive pill, progesterone pill, the Mirena intrauterine system, or GnRH analogs, or surgery. So expectant management, some women might not have heard of this, or it's not offered to them, and it's not for everyone, but this is usually a wait and see approach. It doesn't mean that the patient hasn't got endometriosis and is not struggling or suffering, but some places will offer this because the patient condition can then be monitored by herself and clinicians, and so no treatment is given straight away, especially if they're not sure what they want to do, and it gives them that choice. And that could be, for example, seeing patients with maybe a 5 or 6 centimeter endometrioma, and instead of rushing in to offer surgery to drain it or remove it, when there are other risks involved and they might want to, say, try for a pregnancy, then it can be discussed with them, and the cyst might remain, and they get, if pregnancy is the priority, for example, they will still try, knowing that if things change or the symptoms worsen, they can come back and then go for another option. So it's just another option. Pain control, which has also been talked about, is one of the most common symptoms. So managing the pain for women is a priority. So there are a number of medication, a number of things that women do usually, especially when they've had problems since they started their period. We've heard people talk about just using hot water bottle, heat pads, and having to be very careful. People have burnt themselves with it. Analgesia, which you can just get over the counter, might be paracetamol. And for some women, that might take the edge off. For most women, it won't do very much. And then we have non-steroidal anti-inflammatories. So we're talking about the ibuprofen, the diclofenac, and the naproxen. Again, all of these do have side effects, and you have to be careful as you take them. There's also for some women mefenamic acid, and these block the production of the prostaglandins in the body, so help reduce the pain. And we've talked about opiates as well, where you then go up the pain ladder to look at things like codeine, tramadol, and morphine. Recently, it seemed like a lot of women are now using or are more aware of TENS machine, and these are transcutaneous electrical nerve stimulators. Some places, some bigger booths will lend them out for a small fee, and some women will go onto the internet to buy them. And a lot of women find it does reduce the pain without taking or helping reducing some of the pain. And it works by putting these electrodes which send current to the nerves, and that just help to relax the muscle. It works for some women and it doesn't for other. So also with pain control, especially when you're under like a pain management clinic or some well-informed GPs, you might have some antidepressant, which will affect the way the body manages the pain. And also, unfortunately, when you're in constant pain, for some women, it creates anxiety and depressiveness as well. And also some of the pain are already being used for anti-epileptic stuff like the amitriptyline and the gabapentins, but these help by reducing the pain signals. And for some women, they'll find this, if it's managed properly, it works for them. For others, it doesn't. Diet advice. There is a lot out now about lifestyle, and we know this doesn't cure the endometriosis, but as I always say to the women, if it helps you to manage it a bit and feel better and feel in control, then it will only be like an adjunct to whatever else is going on. So try and eat a balanced diet, try and eat regular and not avoid eating. Reduce things like red meat and processed food, because these don't help with the inflammatory process. There's talk about reducing wheat, and some women will reduce gluten and have gluten-free diet. Speaking to some nutritionists, they also say it's not just necessarily the dairy products. Sometimes women have got like the intolerance to say the lactose or other stuff, but some women will reduce the amount of cheese or egg or other things with dairy. And we're not saying to get rid of them or cut them out, because we know to have a balanced diet, you've got to have everything, but just reduce it and see what works for you. Sometimes around your cycle, you might find certain things causes your bowel to be worse or be better. And you can do a diary to just see how, what works best and what to reduce, what will reduce bloatedness and all that sort of stuff. Increase your fluid intake. Sometimes we're not necessarily hungry, so the fluid might just help, but avoid things like fizzy, sweet drinks. Sugar is in everything that we eat. So if we can avoid added sugar, then that might help with the inflammatory process and just hopefully make you feel a little bit better. Exercise is always good. Very much understand that if you're in pain, it's the last thing you might want to do. But there's research going on and encouragement to say, if you can manage to do, whether it be 10 minutes of walking. Walking is very good. You don't have to go anywhere, you don't have to pay for it. But obviously when you feel like you can manage it, I always suggest to ladies as well, maybe yoga or Pilates, because they're not high impact stuff and it just little stretch, and you can modify and monitor what you do and how much you can manage. The good thing about exercise as well, when you do it, it lets your body releases another sort of chemical hormone called endorphin, sort of like the happy hormone, which also helps you feel better. Exercise might also make you mean that you rest better. And a lot of time as well, if you're in a lot of pain and is anxious and not sleeping, then that also exacerbates everything. And whatever you want to do, whether it be swimming, and some women find running, going to the gym, and more high impact when they're feeling better, that works for them. So very much all of this is just individualized. Pain management team has been mentioned. The difficulty in listening to, especially the women who have told their stories. Thank you so much. I feel so sad when I hear some of the stories, especially I think it was Lexi saying she had to pay for an AMH. And the whole point is, this is what we probably need to do, is to get everything streamlined everywhere. So pain management team, I know not everyone has access for that. Lots of you will know about the BSG accredited center, and many of those will have pain management as part of the process for them to be an accredited center, and GPs may be able to refer you, or within that secondary care you will get referred. They people think sometimes pain management, oh no, I don't want tablets, but they tend to look at you and treat you holistically, which is what you need, mainly led by anaesthetists or the ones that I've been involved with or have visited, that's what I know of. They have physiotherapists, and they help very much as well, because we've got quite large muscles that sometimes get engorged at the front, our thighs, and running down by our sciatic nerve as well. And they will teach you exercises and physio, how to help manage that when you're premenstrual or you're on your period. Psychotherapists, again, maybe other parts of the world are more in tune in going for therapy. We're getting better at that. So it's not to say there's anything wrong with you, but it's to teach you how to manage and help you manage your pain so you can continue to maybe work, whether it be full-time or part-time, look after your family if you have one, manage to socialize and just have a normal life and not be the endometriosis controlling it all the time, which is difficult. And there's also a lot of clinical nurse specialists now in each arena, in endometriosis clinic, in the pain management team where they've studied, and they also can have, whether it be telephone calls or face-to-face treatment with the individual. And some of the drugs that are also prescribed, which I've mentioned before, will help sort of block the nerve pathway. So it's not just, ibuprofen and the paracetamol. So for many of the ladies who we've referred to these, they find it quite beneficial, and others don't. Other alternative therapies, some women have talked to us about acupuncture. Unfortunately, many of these are not on the NHS, and sometimes women have to pay. But there are some centres that do it. Like I know the Royal London Homeopathic Centre does offer it, but a GP has to refer you in. And I'm not sure if it's only a catchment, but that's something that you could try and find out. So some people have acupuncture, some people have cognitive behavior therapy. Some women will go and see a nutritionist and look at their whole diet completely. Psychotherapists, as I've mentioned, mindfulness, meditation, relaxation, and just changing your lifestyle will not cure the endometriosis, but if it can help you maintain and manage and feel better while you await other treatment, then that can only be positive. Hormonal management. Now, many women, as been alluded to in the talk, find it very difficult with hormones. They can have side effects. They can also be positive. So we know there's the combined oral contraceptive pill, probably one of the drugs that's been researched the most. And this contains both estrogen and progestin. They can be taken cyclically or they can be taken continuous. And I think it was Dr. Matthew who mentioned about taking it in the past. It used to be every 21 days and then you have a 7-day break. That's more for contraception. And then it was 3 monthly continuously. The NICE guideline does say now, and I've seen it used a lot, that it can be taken for longer than 3 months. I think the 3 months is for some women, might want to see how they get on, but it is recommended you're under secondary care or your GP that you can take it for much longer periods. And I've known women have taken it for years with no break. There is a caveat that if you do get breakthrough bleeding, then it's suggested that you stop the pill for a week, let that lining shed and you restart it. And obviously the GP, you should be monitored, i.e. your weight, blood pressure and all of that under your GP surgery, but you can take it for a long period because it suppresses the ovulation. So the idea is either reduces the blood loss or you don't have a period, and estrogen feeds, the endometriosis feeds off the estrogen. So if you're not ovulating and you're not producing estrogen, then that will help at least with the period and hopefully with the pain as well. Side effects might be irregular bleeding, especially when you first start taking it. A lot of women don't like it because they get nausea, they get weight gain, they may get fluid retention and breast tenderness, sort of premenstrual type syndrome, changing their mood and mental health. But again, if you are going to try it, you need to give it a good 4 months or so, 4 to 6 months to see how it works, because most medication take that time to settle into your system. And obviously they're researching loads of new pills all the time. So if one doesn't work, it might be the type of progesterone in it and it can be changed. And sometimes it's a matter of balancing to see which one works for you. Progestogens, again, that can be taken oral and by other routes. So oral is the mini pill. Many of you might have heard of desogestrel or Cerazette. That's just 2 of many. Someone mentioned they were on a low dose of norethisterone earlier as well. And there's Dynogest, which is also called Visan. Then there's also Provera, which is the medroprogesterone acetate. And again, these will cause cessation of pure period. They can take 4 to 6 months or more to be fully effective. And with a mini pill, you might find you bleed for a week, you don't bleed again, then you bleed for another 4 weeks. And it can be irregular, it can be irritating, but it tends to settle if you manage to persevere. If this is one, it doesn't give you other symptoms that you can't tolerate. And then the contraceptive implant, mostly use that with the Depo-Provera, which is an injection that you get for 12 weeks. Usually more used on the contraceptive basis, but some women find that it works. The implant can stay in for 3 years. Again, because it's progesterone, you might get erratic and irregular bleeding, the same with the Depo-Provera. But again, just be aware if you're using Depo-Provera and you're planning to have a pregnancy or start a family in maybe a year's time, then think about it, because sometimes the period might not come back for around that time as well. Again, very individualized. And hormonal intrauterine system, the most common one known as the Mirena IUS. This is inserted in the uterine cavity, so it's a little bit more invasive. Can be done in a GP surgery for GPs who are trained to do it. Can be done in outpatient in a hospital, and it's normally licensed for 5 years for women of, I think is who are not menopausal. After that, it can be, if I remember correctly, it's for 7 years. This can take a number of months to become effective. It can become effective within 4 months, and with other women, we've encouraged them to keep it longer if they're not having any major problem with it. Tends to reduce your blood loss for about 80 to 90% in most women if it's working effectively. Also works as a contraceptive because it thins the lining, so the egg will not fertilize and embed, but it can have side effects, which are erratic bleeding, some weight gain, some bloated, and some women find they get regular sort of benign cysts as well.
Elsa, I'm just going to say 1 more minute, please.
Okay, GnRH analog, which is done in an injection form. Again, sometimes it's given pre-surgery, or it can be given under secondary care, under the care of the consultants for longer. It stops your period. Unfortunately, for younger women, it gives you sort of make you think you're over 50s with the menopause. So you might get hot flushes, night sweats, reduced libido, some effect with your mental health, but a lot of women as well find this effective. And the last one before that's recently come out, I think a couple of months ago, the Relogloxic, which is Ricor. Again, that's similar to the GnRH, except it's a tablet that you take and it's already got the HRT in it. And for the women on the GnRH, they will normally be given combined HRT, which Dr. Matti also mentioned, because now we know that it's best to give the estrogen and the progesterone soon after when you give the HRT or if they've had surgery. Surgical management, I'm not going to be able to do, but again, MDT approach is the most effective, where you have the colorectal, the gastro, the urology, and all the teams, depends on where the endometriosis is. You might have just a diagnostic laparoscopy, or you might have excisional or ablation. It all depends on where the endometriosis is, that the surgeon and yourself will discuss that. Or it might be severe rectovaginal disease, so you have to have much more major surgery, hysterectomy, or pelvic clearance, depending on what's going on. But these should be discussed, and you should be very much involved in the decision. And if you're not sure, you should ask all the questions before you go. And although you'll be listed for laparoscopy, it will always say laparoscopy plus or minus laparotomy, just in case it doesn't happen. Sorry, I had to rush that last bit, but thank you very much for listening to me.
Thank you, Elsa. And thank you, everybody. And if I can welcome back everyone who's spoken in that session, we've just got a couple of minutes for questions. One of the things I was just going to ask when we're looking at questions is, I'm going to ask first, just briefly, if either Britt, Shella, or Lexi had any comments on this before moving over to Elsa. Is one of the, I believe a doctor has asked, have anyone ever been given advice around painful sex and how to manage that and work towards enjoyable sex if that is a symptom? I don't know if that's anything that you've ever had help being offered with as a from a patient perspective, Lexi?
I haven't been offered that through a GP. I've done my own research outside of that, but no, it's never been offered.
Yeah, I don't know whether Britt or Shella wanted to or not comment on that at all.
I was just going to say I'm the same as Lexi. It was briefly spoke about more when I went into pelvic floor physio, more from that perspective. But again, that was when I described my symptoms and what I was struggling with, that was never offered to me. And then it wasn't offered, you know, to the pelvic floor physio, that went through a different route altogether.
Yeah. Thank you. Shella, is there anything you wanted to add?
Yeah, the same. I had to do my own research on it, to be honest. No one actually said anything about it, so it was just own research on that.
And I think that's certainly what we hear, and I think that it's one of those ones that I think like I was saying, it seems strange that when painful sex is such a common symptom, and when often even, and I'm sorry, Lexi, because I know this is your story, you know, people are going in asking for help, they're told to, well, have children, you know, why don't you get on with it? And yet no actual support is given. But I do know, Elsa, I do believe there are, I'm not going to put you on the spot totally, but I do believe there are options that people can follow up in terms of trying to improve painful sex. That's something you'd ever advise?
I think it's getting a bit better, and I know not everyone can go to an accredited centre, but on the form that you fill in at the BSG, actually ask about dyspareunia, which is painful sex. So it means that whichever doctor, well, or normally the nurse, will bring it up. I talk about it with women that I speak with, because I ask them automatically if they're in a relationship and they're having intercourse, is it painful? It is very difficult with someone mentioned with a physiotherapist and this pelvic floor. They will help with mild dyspareunia, but they can't do very much for the severe one. There's everyday things that some women can try. You can put a pillow under your back and raise your leg. For some women, find that helps. And again, I'm sure you've tried this. Positional sometimes as well. Talk to your partners, because sometimes just to say, you know, shift that way or move that way or whatever, just so one, it should be a communication thing as well. But obviously for women sometimes who have deep nodules down in the rectovaginal space or anywhere else, and I'm sure Dr. Whitaker will have more to say on that as the consultant, then sometimes they do need to have it removed for them to do. We used to have links to sexual, what do they call it? Was it not psychotherapies? It was thank you very much. And unfortunately, that's so difficult because they're few and far between to refer patients to.
Yeah, no, definitely. Lucy, anything that you wanted to add on that?
So I think painful sex is really common in endometriosis. I think it's incredibly debilitating, and I think broadly speaking, people are probably quite bad about asking about it. I think also it's one of those symptoms perhaps patients feel less confident advocating for themselves, and so you get this awful state where people aren't asking and aren't doing anything. I think there is a lot can be done. Physiotherapy is really helpful, particularly for superficial dyspareunia, so pain around the entrance to the vagina. Physiotherapy really does that, but also can be good for the higher bit up as part of the pelvic floor. Lots of lube, positions, changes, good communication with your partner. But I think there's also a lot of adjuncts now out there about things like O-nuts, which you can use to limit the depth of penetration from your partner. But I think there is all that psychological side around it is really complex. And I think often that can be harder to unpick. And the longer it's gone on for, the more it can have impacts on anticipation, how you view yourself, your relationship. So it can get really hard to unpick all of that, but equally there's an awful lot that can be done. So I would say if you're suffering from painful sex, don't suffer in silence. Endometriosis UK have obviously got great resources, but talk to your doctor about it as well, because there's actually a lot we can do about it. And for some people, surgery is helpful. I've also had people with full thickness endometriosis going through into their vagina who've had amazing responses to hormones, and actually it's completely given them their sex life back. So I think it's talk to someone, and there are lots of things that can be done about it.
Brilliant. Thank you. Now we're a little bit over time, but I've got one last question, Lucy, I'd like to ask you briefly. If you can summarise this in 2 minutes. Is there any research on the best non-hormonal things a patient can do to minimise regrowth of endometriosis?
So in terms of treatments that are now currently available to patients having gone through clinical trials, then no, not in the non-hormonal space. There is evidence for hormonal treatments. But it is an area where there are lots of different groups working. So we've got 3 non-hormonal treatments trials starting later this year. There's obviously the ACES trial, which is already running across the UK. So that's looking at an immunotherapy for deep endometriosis, which I think looks really exciting. And there's also a drug trial that's about to start on a different anti-inflammatory, which by modulating that inflammation, it's not just acting on the pain pathways, but by reducing inflammation, that might have an impact on the scarring as well. So I think historically, we've all focused on the hormone receptors and the hormones, but there's a huge amount happening in this space, and I think it's a really exciting time, but they've just not quite got through the clinical trials yet, but I have no doubt that some of them will.
That's great. Thank you, Lucy. And I think that the other thing I'd say is that we know that different hormones work or don't work for different people. So it's not a case of tried one and the others might not work. Do speak with your healthcare professional about trying different things if the one that you have tried is not working for you. Now, I'm very sorry to say that we have overrun. I just want to say a massive thank you, Britt, Lexi and Shella, for your openness in sharing what is difficult stories and also your practical tips in there, and Lucy and Elsa as well.
It is now time to start the last session of our seminar, and we're going to be discussing the challenges of actually managing endometriosis-related pain. We're going to kick off with Roxana Ahmad, who is going to talk about how endometriosis affected her ability to finish her education. So without further ado, I'm going to pass you straight over. Please, Roxana.
Thanks, Sloan. So imagine waking up every morning and not knowing if you'll be able to make it through the school day. Not because you haven't studied or because you're lazy, but because there's a war happening inside of your body. So I'm Roxana Ahmad, a women's health coach and functional nutritionist, specialized in menstrual health education, and who's someone who's lived with endometriosis for over 20 years, but it took me 15 years to get diagnosed for stage 4 endometriosis. So when I was a teenager, I often had to struggle and sometimes miss school because of the intense period pain. I was told that it was normal. I was told to toughen up. And what was really happening inside my body wasn't just a bad period. It was endometriosis. And I didn't have a name for it until adulthood. So you can imagine all that time from not knowing to trying so many different things, going through so many, just doubting yourself, and going continuously from consultant to consultant, trying to understand what was actually happening, what was going on. I don't think that part of it is actually spoken about enough, because especially when you're in education, if you don't have a quote unquote label, people can't, people aren't able to understand what you're going through. And I think that's a massive piece in the diagnosis journey in itself, having people understand what you're going through to be able to support you. You know, this is the reality, unfortunately, for so many girls, missing school, falling behind and being dismissed. So why does this matter? So the thousands of students in the UK right now, they sit in your classrooms, they walk through your halls, and then they laugh with their friends until one day they don't. And that's because the pain becomes too much. Endometriosis, as we know, is a condition that impacts 1 in 10 women and girls. And symptoms often begin in adolescence, but you wouldn't know by looking. They look fine, you know, so when they miss school, they're labeled as unreliable, or they're asked, oh, you're going home again, and then told to toughen up. And sadly, these are the realities and some of the things that I've been told as well whilst I was in school. So according to the APP Endometriosis Report 2020, a staggering 42% of those surveyed said they often or very often had to take time off school due to their symptoms. And 12% of those reported often missing exams. So these aren't rare experiences. However, there are things that we can put in place to better support the students. So as we know, endometriosis is a condition that often isolates, not physically, but also socially. So imagine you're in school, you're navigating friendships, finding your own identity, your own place in school. And I think that part of it is quite tough enough without unpredictable pain, making you feel left out and misunderstood and alone. And when a lot of students have spoken to me, and they say they often feel dismissed by their friends, misunderstood by family, and also labeled as being unreliable or dramatic. And then in my case, being labeled as a hypochondriac, because people couldn't understand around me how a period could be such a painful thing when they didn't experience it themselves. So there's that comparative element as well. And that's just because, again, it's not a disease that you can actually visibly see. And I think that plays a part in how people perceive endometriosis as well. So despite a lot of efforts to explain the stigma around endometriosis, it continues to separate and silence a lot of women and girls. So like many chronic illnesses, it's a daily challenge, and it impacts more than just health. It touches every part of a young person's life, fortunately.
Thank you so much for sharing your story, Roxana, and for touching on the very sensitivities that affect, young women, girls even, when not being able to be believed by others that their symptoms are in fact impacting on their lives. We're going to hear also from Jenny Hughes-Cook, who is going to talk about how endometriosis affected her career. She is a support group leader with Endometriosis UK, and like Roxana, is an expert by the sheer experience of having endometriosis. Over to you, Jenny.
Hi, so I'm just going to quickly share my little thing with you. So hi, my name's Jenny. Yeah, I'm the Endometriosis UK West Wales support group leader, and off the back of that gave me a bit of a platform to become a bit of an activist and raise awareness about endometriosis in Wales. So I started showing symptoms at 14, but I wasn't diagnosed until I was 29, so it was a 15-year diagnosis journey for myself. I also have a BA in business management. And the reason I'm sharing that with you is because I currently am employed in a minimum wage, very small sales position in a small town, and it is what it is. With a BA in business management, you think I'd be able to have got that a little bit further, but unfortunately not, and this is why. So, yeah. So spending 15 years knowing something was wrong, but not having a diagnosis made it really difficult to be able to prove and explain to employers what was going on with me. Getting GPs to constantly write sick notes for a bad period was becoming a little bit more of a daunting task. It was I felt scared, ashamed, and lots of other feelings constantly going back and forth, more than once a month really, to get these sick notes just to be able to get my employers to understand. A lack of awareness about the condition led to many of my employers and my colleagues to ask and question the validity of my experience. Phrases like, but it's just a period, and don't all women have periods? Why can't you just deal with it? Would get thrown around an awful lot. And that again makes it really, really difficult to be able to just even turn up for work. Even when you're not in pain, it becomes embarrassing, humiliating, having to constantly justify yourself like that. One previous employer questioned why I wasn't doing more to help myself. At this point, I'd lost 5 stone in weight because my consultant had told me that getting my BMI under control would fix everything. So I'd lost 5 stone in weight. I changed my whole lifestyle. And she felt that I wasn't doing enough to help myself, and suggested that if my consultant couldn't do more for me, then maybe it was just in my head. I subsequently left that employment. Another employer, a large UK employer, told me that I had to leave my health at the door and not talk about it. They called me less than 24 hours after my diagnostic surgery, not to ask how I was, but to ask if I could come back to work within the next 2 weeks. This was during COVID, so I'd already had to isolate pre-surgery anyways. They couldn't justify me having any more paid time off for the surgery, and I needed to come back as quick as possible. I, again, subsequently left that job very, very quickly. The financial uncertainty is really, really huge, going from salary paid jobs to hourly paid jobs, relying on statutory sick pay, self-certification. That's something really, really difficult to manage. I'm a working mum, so being able to provide for my family is a huge, huge thing for me. Self-certification alone is almost pointless for myself, because my worst days are those first 5 days, and for those first 5 days I don't get any financial help, so what good is that to me? And I don't think it's understood well enough benefits of things like PIP to help either. The sporadic time off deemed me unreliable, and I got passed over for many, many management positions, my reliability being cited as a reason. Most of the issues, though, I believe, are a knock-on effect of the waiting times for diagnosis and waiting times for and access to effective treatments like pain management, physio and mental health treatment. Faster and easier access to these clinics would have allowed me to get onto a path where I could got that promotion or got one of the many, many jobs I applied for. And I do think that a lack of coverage for endometriosis by the Disabilities Act has really not helped in my favour. I don't feel like I've had the support that I've needed in terms of occupational health, or even, again, being able to apply for things like disability benefits like PIP. It's made it really, really difficult in a financial sense for me to be able to juggle really, really hating myself by having to work more than I can really do, or sit at home and hope that I'll get the support that I need.
Thank you so much, Jenny, for sharing also your journey, which has not been easy. And with these two examples, and there are obviously tens of thousands more out there, has really emphasized the importance of us being able to manage endometriosis so that young women can finish an education and move on to have a meaningful career, but also highlight the overall lack of infrastructure and support there are for those who are not perhaps able to work full time. That, unfortunately, is a whole seminar in itself.
100%.
Before we move on to how to manage endometriosis, I think it is also important for us to understand the actual pain mechanisms that are involved. And that is going to be addressed by Lydia Coxon, who is a senior postdoc researcher at the University of Oxford. And she is specifically going to be talking about the mechanisms of pain and endometriosis, in the hope that that will help us also to better manage the disease. Over to you, Lydia.
Thank you, and thank you very much for having me with such an amazing array of panelists. So I'm really thankful for being here. So firstly, I have no disclosures or conflicts in relation to this presentation, but I am funded by the Medical Research Foundation. So I'm going to start with the what is pain? And with this, I want to have a caveat. So I'm a neuroscientist. So my background is looking at the brain, is looking at nerves and things like that. So to me, pain is in the brain, in that the brain is the organ that pieces together the complex picture that is pain. But what I want to say with this, and what I hope that this sort of summarizes, is this quote here. So is this all real, or is it just happening inside my head? And of course it's happening inside your head, but why on earth should that mean it isn't real? And when I talk about pain being in the brain or being in the head, that is what I mean. I don't mean you're making it up. I mean that the brain is the thing that's piecing this all together in the whole complexity of pain. So just wanted to get that out first, because I know that can seem quite dismissive. So that is where I'm coming from with this. So the International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience that's associated with, or resembling that associated with, actual or potential tissue damage. And to go alongside that, the ICD-11, which is a sort of clinical tool to use for different definitions and things. They define chronic pelvic pain as chronic or persistent pain that's perceived in structures related to the pelvis lasting more than 3 months. So again, when I talk about chronic pain, it's about the duration of pain, not necessarily the intensity of pain. As has been said, we know that there's not a good correlation between the stage of endometriosis or what the disease looks like in surgery or in images and how that pain is perceived. And this is because there's such complexity and so many different mechanisms in endometriosis pain. So I'm going to talk a bit about these. So historically, we thought of a very classical view of what we'd call nociceptive mechanisms. Now here, for those who aren't familiar with textbook anatomy things, this is the uterus, the spinal cord sections, and then the brain. So the very classical view of pain is that you have this, something happens in the periphery, you touch something hot, or there's inflammation, that signal travels along nerves up the spinal cord to the brain, where the brain then perceives it as pain. Now that's targeted by treatments like ibuprofen and anti-inflammatory medications target that sort of pathway. It's the pathway we're all familiar with. That's what happens when we stub our toe. There's that message following up. But what we know in endometriosis is this isn't the whole picture. And there are other mechanisms in chronic pain that could also be part of this complexity that is endometriosis-associated pain. So the first of these that I want to talk about is something called neuropathic pain. So neuropathic pain is pain due to disease or lesion of the somatosensory nervous system. What that means is that there's damage to the nerves themselves, and that is what is causing the pain or driving that pain signal to the brain, is the damage to the nerves themselves, as opposed to damage to the tissue around the nerves. So there's multiple reasons why there might be neuropathic pain in endometriosis. So we know with any surgery, there's a risk of neuropathic pain as a complication to that afterwards. So we know that obviously surgery plays a big part in endometriosis diagnosis and treatment. We also know that the lesions themselves of endometriosis have new nerves that grow into them. And these new nerves are squished by the lesions, they're surrounded by the sort of inflammatory soup, and all of these sort of things can mean that there could be a neuropathic pain in endometriosis. Now, one of the ways we look at these sort of things is asking about how you feel them. So if you imagine stubbing your toe, you might describe that as aching, it might be throbbing, things like that. If you hit what we call your funny bone, and you have that shooting pain down your arm, that is a sort of neuropathic pain. So that's because you're hitting the nerve and it's sending that signal. And that can be like tingling, they can be shooting. Those sort of descriptions can give us an indication about the mechanisms that are underlying them. So one of the things that uses this is a tool called the Pain Detect. Now this is just a very nice questionnaire and it asks questions about the time course of your pain. So whether it fluctuates, whether it's a constant level with attacks. And it also asks about how you describe it. So whether it was burning, whether it's tingling or prickling, whether light pressure in this area triggers pain. And these are all things that we think of as typical of neuropathic-like pain. Now, the reason I've said neuropathic-like is because this is not a diagnosis. We can't use this questionnaire as a diagnosis, but it gives us a good indication. One of the other things it asks about is if you have any numbness in this area, because that's also something that we see when you have this damage to the nerves. Now, when we looked at this as an online questionnaire with Endometriosis UK and others, we found that we had over 1,400 responses, and of those, about 40% fell into this neuropathic group. So 40% of those people had this sort of neuropathic-like, so the tingling, the stabbing, the shooting, the numbness. When we look at how that relates to the symptoms, you can see here 14% had what we call clinically significant numbness. Now, these are all hallmarks of this sort of nerve damage-like pain. The important thing to know is that this nerve damage-like pain doesn't respond to things like ibuprofen and paracetamol, like people have said. So we need slightly different pain medications to treat it better. The other thing we looked at in this was the number of surgeries people had had to the abdomen. Now here in the blue line, so you can see as you go along, the blue line's going up. So this is meaning as people have had more surgeries to the abdomen, there's more of people that are falling into that neuropathic group as opposed to the others. Now, what this could mean is that people who have this neuropathic type pain aren't responding to surgery, so are being offered repeated surgeries that are also not being effective, and they're in a vicious cycle of surgeries that aren't working. It could be that the surgeries themselves are causing this neuropathic pain that we know is a possibility of a possible outcome of surgery. So we don't know quite where it is, what is causing that, but it's interesting to think about, especially if we think about repeated surgeries in endometriosis. So another way we can look at this neuropathic-like pain is using something called quantitative sensory testing. Now, what that is there's lots of different tools that we can use to poke and prod and see how you feel different sensations. So we can see how you feel temperature changes, pressure, vibration, little metal rods and things like that. So that gives us a good picture of how the nerves are working and what your sensations are like in different areas. When we've done that with people with endometriosis, we can see it allows us to group people into these different things. Now, these different colours here are showing different mechanisms, basically, that we think are underlying the pain. This blue is this sort of sensory loss. There's these nerve loss. This meaning there's a loss of sensation there. And the grey is people with a healthy profile. So very few people in this cohort had what we call a healthy profile. So they were responding to these sensations much differently than we'd hope for in a healthy population. So if we add then neuropathic mechanisms onto this diagram here, the other mechanism that I want to talk about is nociplastic mechanisms. So nociplastic pain, and these are lots of terms that are not particularly nice to get your mouth around, but nociplastic pain is defined as pain that arises from altered nociception despite no clear evidence of actual or threatened tissue damage causing activation of peripheral nociceptors or evidence of the disease or lesion of the somatosensory nervous system causing pain. Now, what that all means is that there's changes somewhere along that pain processing pathway that mean that the way that your body processes pain and the way your brain pieces it all together is different. Now, one of the things that's of a condition that's thought of as nociplastic is something like fibromyalgia. So the sort of hallmarks of nociplastic pain are like widespread pain, so pain that might be outside of the pelvis, outside everywhere else in the body. Also things like brain fog, which we know are really common, fatigue, which I know has been mentioned as well. And these are all symptoms that we know are really important in this nociplastic pain and the mechanisms underlying that. So there's also some questionnaires that we can ask around that. So questionnaires can be really, really powerful. So this is some of the questions we might ask about that. So we might ask about where on the body you feel pain. We might ask about whether you have fatigue, whether you have problems thinking and remembering things, or waking up feeling unrefreshed. We might also ask if you feel pain and have headaches, you're sensitive to bright lights and things like that. That can all give us a picture of this sort of nociplastic mechanism. So it means that there's changes somewhere in that brain processing pathway. Now we know that this nociplastic pain seems to be prevalent in people with endometriosis, and it's often associated with a higher symptom burden. So those with a sort of more nociplastic pain, more widespread pain, often have higher pain intensity and greater pain interference. We also know that this pain doesn't respond as well to hormonal medication, and we know that these people often don't respond as well to surgery as well. So it's really important to try and think about this when talking about treatment options and things. So then if I pop nociplastic mechanisms on here, you can see this is starting to get a little bit more complicated. Now, what I don't have time to cover in quite so much depth, but there's lots of other things that impact pain. So just to go through them, very skimming the surface. But we know that depressed mood and anxiety has a bidirectional relationship with pain. So we know that naturally, if you're experiencing pain, you're more likely to have a lower mood. But we know that if you have a low mood, you're more likely to experience greater pain. So there's some really cool studies where if you take healthy people and you play them sad music, so you play them really sad music, it lowers their mood. If you give them a pain stimulus, they feel that pain more. And that's because this mood and this depression and anxiety particularly can have this bidirectional relationship and a vicious cycle with pain. We know that visceral hyperalgesia is really important. Now that is really a mouthful, but what that means is that the organs in the pelvis can sort of sensitize each other in a way. So symptoms you might experience symptoms in the bladder or in the bowel, and you have this sort of general sort of widened sensitivity across all those organs that sit in the pelvis. We also know that pain-related cognitions or thoughts are really important. And one of the things that's really important here is how you think about pain, whether the pain makes you feel quite helpless, but also things about your expectations of pain. So I imagine most people have heard of the placebo effect. So if you give someone a sugar pill, they will have a pain reduction. But the flip is also true. If you give somebody morphine but don't tell them, they don't get a pain reduction. So what you're expecting with pain is really, really important. We know that sleep is really important in chronic pain in general. And again, it's this bidirectional relationship where sleep can particularly impact sleep can impact your pain, but also pain can really impact your sleep. And especially if you've got associated symptoms, sort of urinary frequency during the night and things like that, that also will impact your sleep. And again, it can be a bidirectional and a vicious cycle. We know that the gut-brain axis is really important. So I know some people have talked about it, so we can look at the microbiome in the gut and look at all these sort of things. But we know that the gut and the brain talk to each other and do some really complicated things. And we're just starting to scratch the surface of all of that. So when we piece all of that together, we have a picture something like this. So we have, hopefully I can do the laser pointer. So we have your neuropathic mechanisms, so the damage to the nerves themselves. You have this organ sensitivity, so this visceral hyperalgesia where the organs are sensitizing each other. You can also get viscerosomatic referral, so you can where you feel the pain on the surface of your body, on your sort of lower abdomen. Talked about this gut-brain axis. These nociplastic mechanisms and these changes, you can have changes in your brain structure, brain function. We know that the HPA axis is really important, your stress axis and things like that. And we know that there's this really complicated relationship between sleep, fatigue, and depression and anxiety. And they can all impact each other and impact on pain. And we know that pain obviously has a massive impact on quality of life. So when we're piecing all that together, it's beginning to be apparent why endometriosis pain is so complicated and so difficult to treat. But what I'd like to just end on is why these mechanisms matter. So if we take a population of people with endometriosis, with different ethnicities, gender identities, ages, physical abilities, fertility wishes, comorbidities, you take how they come to clinic when the symptoms that they report, so period pain, pain with sex, pain outside of the period, with urination, with defecation, you might have mood disturbances, sleep fatigue, as we've heard, a massive impact on work and school, and all those things pieced together. And we know we have a variety of different treatments that we have that are effective for different people. But what we're not great at yet is matching up and how we call it stratification, but how to get from all these symptoms to these different treatments. And that is where mechanisms can be really, really helpful. So just my takeaways. So there's lots of different mechanisms underlying pain and endometriosis. These mechanisms can happen in combination and they can be different for different people. And in research, we're trying to learn how to identify these mechanisms and work out which treatments would work best for whom. So thank you.
Thank you so much, Lydia, for this excellent course on pain mechanisms. I learn something every time I listen to you, and I wasn't disappointed today either.
Thank you.
This is also a really great introduction to our next two lectures, where we're going to be talking about how to actually manage that pain and why those pain mechanisms matter when we determine what the best treatment strategy is for those with endometriosis. It's my pleasure to introduce Dr. Shaheen Ghazali, who is a consultant gynecologist at Lister Hospital and well-known, internationally recognized surgeon in particular, but not limited to endometriosis. Shaheen, over to you.
Thank you very much, Lone, and thank you for having me. Well, first of all, can I say how wonderful a talk it was from Lydia. I learned quite a lot. Probably one of the best talks I've heard in the last year, and I listened to many talks. And actually, that was a very good introduction to what I am going to talk about. So, I'm a surgeon. My job is to remove endometriosis when surgery is indicated. And what I want to talk about tonight, firstly, is just to give you my take on the state of affairs when it comes to surgery for endometriosis, both in the UK and worldwide. And hopefully, I will have some positive messages to give, because we hear so much doom and gloom in this field that I think it would be good from time to time to see the positives. And secondly, I want to prove to you that what I do may be a little bit important, but it really isn't the whole story. And I am only one of the things that is necessary in the whole journey of women like Roxana or Jenny, who talked so eloquently about their journey. And as Lona said, there are many, many women, and I listen to similar stories daily. I just finished a clinic, and I can tell you that the story, unfortunately, is so common to hear that people who've been going through chronic pain for years and years, and we are letting them down. So my practice is mostly endometriosis. I would say 95% of patients I see and treat are patients with endometriosis. And what has changed in what I do in the last, let's say, 10 years? The first thing that has changed is the patient group. I mean, that's partly because of the type of practice I run, because I have a referral center. I see very complex endometriosis, and most of my referrals come from my consultant colleagues or from other specialties where surgery is necessary. So it's natural that I see more and more complex patients. But I think things have changed in that field for the better in many ways. First of all, we've become better at surgery. When I look around me, both in the UK and internationally, I really see a lot more surgeons who I would be very happy for them to operate on my loved ones. 10 years ago, that wasn't the case. 10 years ago, there weren't many people that you would look at and say, this is the right way of doing the operation, even if I myself may not have been good to be able to even judge. But I remember the feeling, and I remember that I just felt that this surgery is so difficult that there are only a handful of people who can tackle the disease. That's not the case anymore. We really do have very good surgeons, and quite a few of them. Part of the reason for that is training, of course. Part of the reason is just time. We've learned from each other. We have gone to multiple conferences and live surgeries and gone to each other's operating room. But part of it is because of a change in culture, that we as surgeons, because we're a strange bunch, we think we can do everything, and we think that we don't need anyone else. But I hope I'm right in saying that has changed for the better. We are now more and more open to working together. Multidisciplinary team is now standard in most units that deal with severe endometriosis, if not all. And those units now include other disciplines and specialists. That includes women's health physiotherapists, dietitians, and mental health specialists. I was really interested in how beautifully Lydia put the importance of the way that the brain fits into all of that. This is what I also say to my patients, that they ask me, I have a particular interest in endometriosis of the pelvic nerves, and they ask me, can this pain be a nerve pain? And the reality is all pain is nerve pain. Nerve is what takes this unpleasant feeling to your brain, and the brain is what interprets that. So the importance of a more holistic approach is becoming more and more apparent to us, even to us surgeons. So in my practice, I am now taking advantage of that and explain to my patients that surgery is important, but is not the whole story. It will be important to remove what is causing the pain in many cases, not in all, but without looking after the patient as a person, we're not going to win. What I mean by that is treating the MRI or the ultrasound scan is now considered an outdated method. Believe it or not long ago, when we talked to each other as surgeons, we talked about what was on the MRI or what was on the ultrasound scan instead of talking about what that person wanted, what their wishes was, was fertility important for them or not? What was the priority? And now we have learned, and I hope all of us have learned, that we treat the person and not the nodule, not the endometriosis. A person is not just an endometriotic nodule with some person around it. That may sound obvious, that may sound even condescending to some of my colleagues, but that is the reality. Particularly as surgeons, I hope we've become better not to be like hammers that see everything like a nail. So the answer to everything is not surgery. In fact, in my clinics, the most challenging conversations are not with the patients that have the most complex disease or have multi-organ involvements. The most challenging conversations are with patients that I do not believe will benefit from further surgery. That group of patients that Lydia showed, that keep having further surgery and don't see the response from it. The group of patients that come to me worried that their disease have been missed or have not been appropriately treated. Of course, that does happen, and that is part of the problem. There's no denying that. But we also have learned that not every patient with pelvic pain needs surgery. And I think we need to consider that. The other change that I've seen in my practice is the change in technology and the robotic route. And this is also very important, I think, particularly for our patients who are listening to this, that although I'm really excited about the robotic technology and I love it and I use it and it has improved what I do, I am worried that patients may consider a laparoscopic route inferior to the robotic route and think that because they didn't have robotic surgery to excise their disease, they must have had a less good type of surgery. And I really want to push this point that that is not the case. In fact, worldwide, the person that I consider the best surgeon for endometriosis does not do any robotic surgery, and I always look at his surgery and think, this person is an artist. So whilst technology has helped us and continues to help us, it can also give the wrong impression to our patients and perhaps make the problem worse in some cases. And social media, I think that's another point to make, that we have all seen how in the last 10, 15 years, social media, as well as mainstream media, has helped in really raising awareness, empowering women, showing everyone what this condition can do to people. But I just want to add a point of caution that sometimes we can also worry people unnecessarily. So we need to always consider that this can be a double-edged sword, and it may push some surgeons or maybe some patients to pursue surgery when surgery is not the real answer. So I think, to summarize, we have come a long way. We have become much better at doing very complex operations. I, on a weekly basis, operate jointly with a thoracic surgeon and a colorectal surgeon and a urologist, and we hope we're doing a very good job, where maybe 10 years ago that was more difficult. I think things have become better in how the GPs address the disease. There is room for improvement, there's no question about that. But now the GPs have a guideline. You may not agree with the whole content of the guideline, but I believe that it has been a step to the right direction. What Endometriosis UK has done over the last however many years has been very helpful. And I think, generally speaking, we're going to the right direction. And I'm very optimistic that, that we are going to change how things are done and will continue to improve. Thank you very much.
Thank you very much indeed, Shaheen. I'm going to move this right along, and then we're going to all get together for a discussion about what not only you said, but also what's been said throughout this afternoon. So our final speaker is Pauline Claire Callahan, and she's a pelvic health physiotherapist who specializes in physiotherapy for endometriosis-related pain. And I know that she's been an enormous support to Endometriosis UK in developing webinars and helping those with endometriosis managing their pain in a less traditional way than we're used to with both the hormonal and medical treatments we learned about earlier, as well as surgery. So Pauline, without further ado, I'm going to hand over to you.
Can you see my screen? Can you see my screen?
Yes, we can. You just need to go to the bottom right-hand corner and click on the presenter icon.
Can't see it. Sorry. Not share. Share. Click on person. Sorry. Share. Can you see it now?
I think you need, there we are. And then if you go to the lower right-hand corner and press on the present icon.
Sorry.
Yeah, the lower right-hand corner of your presentation. So you need, there we are.
And I'm afraid
And then
it
in
is.
PowerPoint.
So it's not coming up. Sorry.
It is. You need to go to your stay in PowerPoint and move your cursor to the lower right-hand corner and press on the presenting icon. You're almost there. Bingo. There we are. Perfect.
Okay. Thank you.
Thank you, and I have no disclosures. So this evening I'm going to explain pelvic physio and outline some of the current research and explore the evidence base. So pelvic physio is a specialist branch of physiotherapy that focuses on the assessment and treatment of the pelvic region. And we are unique in a profession in fact that when we're in training, we practice the assessment and treatment techniques on each other. So we absolutely realise how vulnerable and exposed you can actually feel. The aims of pelvic physio are to improve pelvic function and reduce pain. So we provide treatment for bladder, bowel, pelvic, extrapelvic, and the treatment of musculoskeletal and sexual pain. The referral is through your own GP or hospital consultant, or you can pay for private physio. We will always offer you a chaperone or support person, and physio will always be trauma informed. We take universal trauma precautions. So moving on to the barriers and myths, there is a lot of misinformation about pelvic physio. And I'm going to start by acknowledging that sometimes it takes a little bit of courage to attend physio for the first time. It can seem a bit daunting, and there is a kind of fear of what is going to happen, especially for women who have had a lot of pain with perhaps speculum examinations. So let's dive into those barriers and myths. People do fear that it's going to be painful, that it will flare up their symptoms, that it will be embarrassing, that it will take months to improve their symptoms, that it can't help adenomyosis, that's internal, it's very invasive, and that it's only about pelvic stretches or trigger point release, particularly if you read some of the American pelvic physio books. And people also fear that it's not helpful or evidence-based. And in fact, it couldn't be further from the truth. Physiotherapy for endometriosis has level 1 evidence, so the highest level of evidence, and physio really can be very effective. So what to expect? Expect privacy and your dignity to be maintained. We take a full history, and we're going to ask you about your symptoms in your own words, to describe your symptoms in your own words. It's a very holistic assessment, so we want to know what previous surgery you've had, what medication you're on, and all about your symptoms. We then move on to a more objective examination, and we will have a look at your posture, your hips, your lumbar spine, your sacroiliac joint, and we'll do a full neuro assessment on your pelvis. We usually always start with an abdominal examination, and because women with endometriosis hold a lot of tension in their pelvic floor muscles and in their abdomen too. So we use a lot of models to show you exactly what the internal examination will look like. So a model such as this one, so we will explain exactly what we're going to do, where we're going to touch, what the treatment techniques are going to be like. So that can be really helpful for patients. We will show you a pelvis, and we will then show you exactly which muscle, which pelvic floor muscle is the problem. And very much we will do individualized goal setting with you. So it's you that sets the priorities. And as I said before, we take universal trauma precautions because we absolutely realize that in endometriosis, there's much greater awareness of the importance of trauma-informed practice. So trauma-informed practice is very much incorporating these principles of safety, collaboration, choice, control, and empowerment. So we know that 1 in 4 women will have some sort of sexual trauma in their lifetime, and those who are assigned female at birth are at even greater risk of gender-based violence. And as Lexi so eloquently said, sometimes there can be a little bit of medical trauma in endometriosis and fertility trauma. Examining an intimate part of your body can be quite triggering for those who have had any kind of trauma. So moving on to purely pelvic physio, there are many endo-related pelvic floor problems, and this is a lot to do with having overactive, tight, non-relaxing pelvic floor muscles. And endo-related myalgia is very common and it's well recognised. So many women can have that chronic muscle spasm, lots of bladder and bowel symptoms, just because of how the close proximity of the pelvic floor muscles to the pelvic organs, and everything being so tightly packed in that area. Lots of ladies and those assigned female at birth report sharp shooting pain, and lots and lots of sexual pain, pain with arousal, pain during intercourse, pain on orgasm, and pain after sex. And pelvic floor physio can be very beneficial for those. So I've outlined some of when pelvic floor physio is particularly useful. It's great for managing endo-associated pain, for your classic bladder pain syndrome, lots of help for bladder and bowel dysfunction and sexual pain. We can also help with a lot of symptom control. For example, for endo belly and bloating, sometimes by addressing the pelvic floor spasm, you can minimize bloat. And also we can show you how to do abdominal self-massage, which can be particularly beneficial. And we'll go through all the kind of lifestyle restrictions and give you lots and lots of support to safely exercise, because we know that those with endometriosis are at slightly higher cardiovascular risk. So there are many different treatments. Just as there are many endo-related pelvic floor problems, there are many different endo-related physiotherapy treatments, and these are very much dependent on your symptoms. Many of us do acupuncture, and I'm pleased to say that there's much greater awareness amongst pelvic physios and much greater understanding on how to manage or help you manage endometriosis. Let's not forget the humble TENS. Sometimes TENS units can be set at the wrong parameters, or maybe you're using the wrong frequency, high frequency or low frequency, and it depends on whether you're on high dose of opiates and the individual parameters, and also the placement of the electrodes. So I'll not labour the point, but there's lots and lots of different treatments, and it's very much a balance of balancing our physical treatments and this kind of pain education and non-supportive things. But certainly women who come to pelvic physio often will say that they improve their body image and the dissociation they can have with their pelvis. So that's really good. I think that pelvic physio may perhaps be the missing puzzle piece in holistic endometriosis management, when 40% of patients experience ongoing or persistent pain even after surgery. Perhaps endophysio could be the key in helping with symptom management. So this is perhaps my most important slide, and this is relating to the differentiation between the reoccurrence of endometriosis and the reoccurrence or persistence of endo-associated pain So 40% of patients will experience persistence of pain even when they have had specialist excision by an endometriosis surgeon. And we know that the reoccurrence rates of endometriosis are high. And it can be a real roller coaster of emotions for patients when they are absolutely feel that they're waiting on surgery and they can do nothing in that pre-lap stage. But perhaps by accessing pelvic physio and having pre-lap prehab and indeed post-lap pelvic physio rehab might also be really, really beneficial. So yes, in this picture, it shows you the endometriosis surgeon who has removed all microscopically visible endometriosis. He has restored the normal anatomy. He's improved fertility outcomes. But because the pelvic floor drivers of pain have not been addressed and the brain changes, the central sensitization, then it's likely that that patient will have ongoing or persistent pain. So as a pelvic physio, I take a biopsychosocial approach to assessment. So I am looking at you, all the factors that are driving your pain. And the biopsychosocial is a kind of holistic assessment. And it's really important that we do that, because the rates of persisting pain are very high. So pelvic physio really can help change the inputs to help change the outputs. As a pelvic physio, I treat the pelvis, but I treat the whole person attached to that pelvis, because pain doesn't just live in your pelvis. It lives in your brain, your muscles, your fascia, your breath, your stress response, your thoughts, your beliefs. Persistent pain makes the nervous system hyperreactive, even to things that are not dangerous, thinking peripheral and central sensitization. So nervous system practices such as breath work, massage, gentle movement, pain-free exercise signals to the brain's safety and interrupts that stress cascade and immune response. So pelvic physio changes the input to change the output. So the highest level, one evidence for multimodal physio, very much in that multidisciplinary team, comprehensive approach, combining lots of different tools and strategies. And often we will break your goals into, reverse engineer them, to break them down into small steps to help rewire that safety back in, so resets that up regulation, because endo is complex and it needs expert care. So it's individually tailored, and very much pelvic floor is much more than the floor and the core. It's a balance of individualized nervous system regulation and local tissue treatments. Endo pain is not just about anatomy, altered pain pathways and immune response. And the evidence for multimodal pelvic physio is enormous. Thank you.
Thank you very much indeed, Pauline. It was a lovely end to all the different perspectives that we've had on managing endometriosis this afternoon. I think one of the things that stood out in all of the those with lived experiences testimonies is the importance of that diagnosis, that label, if you like it, so that others understand what it is that you're going through, but certainly also so that you can seek the correct management for what you're going through at any given time. And I want to just go back to the presentation by Stacey Misma, where she emphasized that that diagnosis both differs in terms of when it happens and how it happens, depending on when that woman is captured with the symptoms she's experiencing at that time, and then subsequently and consequently, so does the treatments that are being offered to her. Very, very complex and very, very important that we address this better to alleviate not just the personal burden, but quite frankly, also the societal one. I am going to, now that I've mentioned Stacey Misma by name, I'm actually going to call on you, Stacey, because I know that you had a comment pertaining to the presentation by Shaheen Ghazali. So please.
Well, and actually, I think I can, Shaheen and all of the presentations were brilliant. I think I can open this to the full panel, which is what has been reinforced throughout this day, but particularly in amongst you, smaller group in this last session, is the importance of multidisciplinary collaboration, expertise. Again, at different points across their lives, patients will need different things, but also there will be some patients for whom certain treatments will not be the right answer. There will be some patients for whom those treatments, surgery perhaps was effective in the past, and a repeat surgery is not now effective. So I want to open up to, particularly given, and start with Shaheen, that the field has been, for a lot of good and for some ill, very surgeon-centric. How do you see the surgeons now, as you so nicely said, now that there has been this shift in recognizing these multidisciplinary needs and approaches and the diverse patient needs? How do you see surgeons and the multidisciplinary teams working more effective collaboratively, and starting with Shaheen and then perhaps moving to Lydia and Pauline and Jenny in the group?
Thanks, Stacey. So look, I've seen this in my own practice, and I'm fortunate enough to have a lot of control over how I design my practice because I work in the private sector. The knowledge is one thing, the logistics and being able to bring all those people together and the cost that is associated with it, both within the NHS and outside, is part of the challenge. I think more and more we as surgeons have recognized the importance of multidisciplinary approach. And by multidisciplinary, I actually don't mean the urology, colorectal, thoracic surgeon part of it. That has been there for many years. Okay, that's nothing new. But I think more and more we recognize how important pelvic floor physio is, how important diet is, how important mental health input is. But how to bring all of that together and how to make sure that the patients don't feel that they are just being referred to other people and they don't feel that, for example, the mental health is a very sore point. And Lydia, I think, put that in a beautiful way. That how do I make sure that when I offer to my patient that perhaps you would benefit from a clinical psychologist input, they don't think I mean that this is not real or you're making it up. So that there are several challenges and barriers. How do I see this? I think with more and more evidence gathering and more people recognizing the importance of other disciplines that we've heard from today, the more the patients will ask for it. And I think that's how we can progress. Patients demanding from the surgeon that, okay, I know I need surgery, but do you have a women's health physiotherapist in your team? Or can you refer me to a mental health professional?
Thank you. How do we get other surgeons to think likewise?
It's a difficult one. I think all surgeons, I hope all surgeons that work in endometriosis recognize that what we do is different to, I don't know, a gallbladder stone or a knee problem. And I don't mean to reduce what my orthopedic colleagues or general surgeons do, but I doubt that any surgeon working in endometriosis doesn't know this. I think making it more accessible to them and also improving the acceptance of the patient exactly by what you are doing today would be a helpful addition to it.
Thank you very much. So we have a few questions coming through the feed here, and I'm going to start with you, Lydia Coxon. And this is a question from Emily. How could I start the process of getting all the tests that you mentioned, the brain fog, poor memory, sensitivity to light, and lower pain tolerance are very relatable. And if they can be improved or managed, this would be very helpful. Any thoughts on that?
That's a great question. So I think all the things that I've talked about have been things that have been done in research. So most of the testing stuff that's been done in a research setting. But I think especially in sort of pain clinics, these are the sort of things that they would ask about these things because they're familiar with these sort of mechanisms and why these questions would be important. So I guess that would be somewhere where I think that would be asked, but it doesn't mean that it's not something you couldn't record yourself as well. And I know that a lot of the people with lived experience have said that pain diaries and things like that, keeping a diary can be really useful. And I think including symptoms like that and brain fog can be really useful for you to then take to clinicians.
I think that's very helpful advice. Then we have a comment from Charlotte Biswell, who says it's frustrating that there's not automatic referral to pelvic physio. I too believe that there should be prehab and rehab pelvic physio either side of excision surgery. Pauline, what can we do to make that happen? How can physical therapists help those with endometriosis or work with surgeons to make that part of the treatment algorithm, if you like?
I've certainly seen in the last 20 years much greater awareness in pelvic physio about endo, and our special interest group, the POGP, is really pushing the endometriosis agenda, and I think it's just really important that we have these events, and that Endo UK and endometriosis.org are really putting out resources. But I think it's a slow process, but I've definitely seen improvements. And I think I would definitely urge surgeons, if you have a patient who is coming back within 6 months of surgery and they have persisting pain, that really should be a red flag to get them to physio, because it might be that they are centrally sensitized or that they really have significant pelvic floor dysfunction that we can really help.
So this has absolutely just generated some response questions. One is from Megan. How soon after excision surgery would it be recommended to start pelvic physio if this was possible? And Pauline, that's over to you again.
That's over to me. I would say probably in 6 weeks. Leave the body to settle. Certainly not before 6 weeks after surgery. But again, that I would always defer to the surgeon what his preference would be, but I wouldn't be doing pelvic physio on somebody before 6 weeks.
Can I add something to that as well? I agree with
certainly may. Thank you.
What I also think is helpful is not to leave women's health physio or the mental health input as for when surgery hasn't helped. I think what we've started doing is to involve all of that team even before the surgery and reassure the patient that, we're not saying I won't do your operation, but we've created something called recovery and resilience pathway, And in that, we have the mental health team, we have the women's health physio, we have the specialist nurse, we have the dietitian. And before surgery, we are now referring the patients to see and meet these specialists and start those even before surgery, so that it's not for failed surgeries for everyone.
Yeah. The only thing I would add is the kind of nomenclature has changed, and the fact that we prefer to be called pelvic health physios because we do see men, women, and sometimes children. So we're not exclusively women's health physios.
Thank you for that clarification. We have one final question, and this is for Shaheen Kazali. And I think it's almost a straightforward yes or no. Do you perform laparoscopic surgical operations for rectal obstructions due to intestinal endometriosis associated with a frozen pelvis?
I think I answered it before you asked the question. The answer to everything is yes. But seriously, yes, that's a very rare occurrence, however. You know, that's important to say, that even with very large rectal nodules, it's very rare to see acute obstruction. We have subacute and intermittent obstructions that we see from time to time. But yes, if that is the case, surgery is actually one of the important indications for surgery.
Thank you. I think that was a very important point, that when we talk a lot about deep endometriosis and deep nodules and very fibrotic disease, that is not necessarily the most common forms of endometriosis. And whereas some of that responds well to surgery, one of the challenges we do have, and I don't know whether Lucy is still on the call, is the whole issue of what do we do with, you know, superficial disease. And that's not knocking it as not important, but it is when there is very little disease and it is quite sporadic. And as Lydia emphasized, repeat surgeries are not necessarily the solution. Lucy, would you like to sort of have a final comment on that particular challenge?
Well, I think firstly, I would say at the moment, we don't really know what the role is of surgery for superficial endometriosis because the existing trials have been very small. They've not had very long-term follow-up. And so that's why it was really important that NIHR funded a trial that was going to be large enough to specifically answer that question. And we're incredibly grateful to everyone who's taken part. And we've now completed recruitment to that trial. It's got 400 patients randomized, and we'll be reporting next year. I don't know what the answer is going to be, but I think whatever it will be, whatever the answer is, it's going to be really helpful for how we counsel people about what the role is of surgery for superficial peritoneal disease. I think if it does show that surgery is not significantly helpful at improving pain and quality of life for that subtype of disease, then what's going to be really important is about having clinical trials that are specifically looking at medications and other forms of pain management for this subtype of endometriosis, so that we can then give people better evidence, again, with which to make decisions about what they want to do to manage their symptoms. But I think at the moment we don't know, but it's fantastically important that the trial's been done, and we will have a much better idea next year when the trial reports.
Thank you very much. And on that note, we're left with tons of unanswered questions and the need for more trials, more studies, more investigations. I'm going to thank everybody who participated in this session, and then I'm going to hand over to Emma Cox to make conclusions for this afternoon. Thank you, everyone.
Thank you, and thank you, Lorna, for a great session as well. Thanks to all the participants for staying late into the evening. And I think, as Lucy has just said, what we are hearing very much today is that endometriosis isn't a disease where everyone has exactly the same thing. Thing being a medical term, clearly. So everyone has different symptoms. There's different types of disease. We will find out more over the coming years when there's more research. And so I think for all those healthcare practitioners on the call, considering that really thinking about how do you support the person in front of you to understand their symptoms and their experience and get them the help they need, rather than going, well, the last person did this, so that'll be the same. It is incredibly difficult, I know, being in general practice, but actually if we can't help people with pelvic pain to get towards their diagnosis and access treatment, then we are depriving often young people of their ability to achieve at school and to achieve at work. So it is really important. So there's that real thing, you know, endometriosis is an age disease. We need to know more about it. Thank you to the researchers. We will know more in the future. There's a need for personalised approach, and very much has been stressed by others in the last session, the multidisciplinary approach. So again, considering the person in front of you. And again, as Lorna said earlier, really stressing the need for a diagnosis. I know back in the day, so we're talking like the 70s and 80s, possibly creeping a bit further into the noughties, but sometimes you'd hear the refrain, well, does it matter if someone gets a diagnosis, because what are we going to do about it? And the answer is a resounding, from my perspective, absolutely we need to get people a diagnosis so they can put a name to the symptoms they're experiencing, so they can believe what is happening to them rather than being told it's in their head. And I think also at the moment, the diagnosis time is going up due to the impact of COVID. So we're saying an average of 8 years and 10 months at the moment in the UK. And I think that, as we've heard, we do know from our own research at Endometriosis UK, probably about 10 to 13% of people get diagnosed quite quickly within a year. But as we heard from Jenny, and then Jenny spelled slightly differently at the beginning of the day, sometimes it can take 20 or 15 years to get a diagnosis. So again, if you think of the person sitting in front of you, the healthcare practitioner, of the sheer impact of not being believed or being treated for that length of time, the impact that can have on someone's mental as well as physical health. So again, diagnosis, yes, it's a really important thing for the individual, and it will lead to access to the management that the person can get. Is management and treatment perfect at the moment? No, not yet, but we are getting there. And I think Lucy and Stacey have outlined that. And I think, again, also thinking about different pain mechanisms. Lydia, I could listen to you for hours, and we must get you on a full session doing one of these. And I think Shaheen is right to say that patients should demand more from healthcare practitioners, but I would also say that healthcare practitioners need to also support patients, because not everybody has the education, experience, or knowledge in order to challenge healthcare practitioners. I've got doctors in the family, so I'm quite used to having an argument with my brother and other doctors, but that isn't the case for everybody. And I think that, again, I know there's a lot that is done within healthcare practitioners and general practice to support patients, but again, and I think we heard Charlotte gave some examples earlier on about the impact of different cultures. Excuse me. So I think there is very much around, yes, let's support Endometriosis UK and others, let's support patients to really advocate for themselves, but also let's make sure that those people who are less experienced still get the care that they need. And so I think going forward, the thing I'd like to say is I think it's been a really positive event. I think there's some real, really good support is out there. A really big thank you to the Royal Society of Medicine for allowing us to work with them. It's been really great to reach a whole range of people. And I do want to thank everyone who's spoken. And we've had some great researchers, healthcare practitioners, but I think most powerful has been hearing the experts by experience to put into context what that's like on the ground. So that's all I wanted to say, unless Lorna wanted to jump in and say anything I've missed. I just want to say thank you all for joining us. We're now 2 minutes over, so I'll say thank you very much. If you have outstanding questions, drop them into us and we will look at getting those answered if you send them into RSM or to Endometriosis UK. And thank you to everybody for joining us and for speaking. Good night.